Good morning and welcome to the board of the MCA for July. I'd like to welcome also all those who are participating or listening via on-screen communication of this meeting. Just a few things before we go into the meeting proper. It is Wednesday, so just to remind ourselves that there's likely to be a fire alarm. We intended this meeting finish at 12:30, so the assumption is that everybody has read the papers and we go straight into questions. And we are in Perda, so I suspect I probably don't need to remind either colleagues watching or those who are at home following the streaming of this. So we must remember that since this is Perda, and before the election, we have to take great care to avoid anything which may have any implications for political changes, especially in relation to the NHS. And I will remind colleagues, and not just remind them, they transgress that we cannot continue this forward. And then finally, I really want to emphasise that there are two items on this agenda which are new, and I'm very pleased that they are on the agenda because they demonstrate our openness and transparency, and also the huge amount of change which is taking place at the NCA, and more importantly, how to change in relation to change portfolio board is an addition to our assurance processes, and they will continue to be on part one on the agenda, as indeed will be coverage of the green recommendation oversight. Having gone through those housekeeping, could we turn to the colleague's story? And Estelle, would you like to introduce?
Yes, of course. I'd like to introduce Sharon Jones, who is here to, Sarah Jones, apologies, who's here to provide us with a colleague's story.
Thank you. Hi, I'm Sarah, to our executive and non-executive members of the board. Thank you for the opportunity to present our complementary therapy service for colleagues to improve their health and wellbeing. Our service offers our colleagues across all care organisations the opportunity to access complementary therapies such as back, neck and shoulder massages, Reiki and reflexology within the working day and within time slots that do not cause a disruption to everyday life within the Northern Care Alliance. This is done by offering a monthly therapy session at all care orgs where colleagues can book onto a wonderful complementary therapy session. For those that cannot leave their environment, complementary therapies comes to them to ensure that this service is more accessible. This has been particularly effective in teams such as critical care and midwifery services, where they've benefited from a course of therapies. Using ESR data and requests from teams where colleagues are experiencing high levels of stress and anxiety and absence has also allowed us to develop a service that is being specifically targeted to support colleagues and teams in need. This has also been used to support colleagues with absences due to musculoskeletal issues with great effect. The service also involves training our dedicated team of 100 volunteers to offer complementary therapies within their workplace. This is agreed by line managers as they see the benefit that this service can bring to their teams and are frequently requesting for their teams to be trained to be able to support their staff. Training of colleagues has shown to significantly impact the feelings of being valued and part of a team and has a direct impact on improved feelings of wellness of all of those involved. Since June 2023, over 2,222 therapies have been delivered to our hardworking and dedicated MCA colleagues. And we have a service where new colleagues book on to receive a therapy, where regular colleagues attend on a monthly basis to receive their moments of calm. Over 1,400 of these are for colleagues who come for the first time to receive complementary therapy. The remainder are people returning each month as they've felt the amazing benefits of the therapies they receive. This service is used by over 290 teams. From our colleagues in estates, anaesthetic support, histology, infection and prevention control, EDI, the resuscitation teams, colorectal, critical care, governance, housekeepers, directors and the management team. It's a fully inclusive service. Without exception, colleagues are so thankful for receiving complementary therapies as they have an opportunity to relax and unwind. Most report feeling calmer, more motivated, physically better, more relaxed, cared for, and feel their well-being is significantly impacted. Many comment on how needed this service is, and they desperately want it to continue. Many also feel part of an organisation that cares about them and their well-being. Most also return, most bring a friend, or they embark on training. Some colleagues have been able to access support for things they're experiencing in their life, such as depression, addiction, or grief. Sometimes having the opportunity to talk about how they feel has helped them to access support from the GP or family members. Complementary therapies provides a safe space for people to open up about things they might be struggling to cope with, and it can be the first step where they feel accepted and cared for and accepting that they need help. 52 colleagues report that it stopped them going off sick. When teams train and offer this within their own environments, we've seen huge improvements in the well-being of the team, where they feel better able to cope, have less sickness, lower levels of anxiety and mental health issues. And those who are offering therapies get a great deal from giving something back to their teams. Without exception, all teams request more therapies. They ask for more of the team to be trained, and they report the positive impact that this is having in many other ways. This is evident from tests of change in cellular pathology in Oldham and Salford, Rochdale community nursing teams, Salford adult social care, critical care, Oldham community teams and Bury theatres. The complementary therapy team also get a great deal from being part of the complementary therapy team. They report feeling more positive in the roles and looking forward to the days when they're offering therapies. The impacts of this service have had significant impacts on the health and wellbeing of our colleagues. They report feeling more relaxed, in less pain, calmer, and ready to face whatever they need to in their working and home environment. They feel valued and respected. We've developed great working relationships, not only with our amazing complementary therapy champions, who without this service could not be as successful, but also with every single colleague in our care. The continuation and expansion of this service will mean that we can increase our offer for more of our colleagues to experience the many benefits of complementary therapies and also expand this much needed service to our patients. The amazing results we've seen so far are just a fraction of what can be achieved. With continued support and expansion, we can continue the amazing work to ensure that more of our people are impacted by the fabulous benefits of complementary therapies. And now if you have any questions, myself or Julie would love to answer them for you.
Colleagues? Ravina.
Hi, Ravina.
Hi, thank you very much for that. It's very powerful. You provide great insight into the range and diversity of therapeutic support you provide. I don't underestimate for a moment how important it is to our colleagues, because it has an indirect impact on their own persona and how they then provide high quality care for our patients' care, their families, and also to each other, actually, because they are a support system, but particularly in the context of increased mental health challenges and difficulties, and particularly around some of the burnout issues that police talk about. the need to reflect and pause is integral to how they go to work. As I said earlier, support each other, and your role just a tone of your voice. This was so, his manner so soft and gentle. I just want to be there. Therapeutic experiences, but thank you very much.
Thank you, Ravina.
Supporting it.
This service is having a huge impact. It's come so far in a year. I've been in post for just over a year, and it's come so far, but it's just a fraction of what can be achieved. You're absolutely right. Incidents of burnout, lots of colleagues that we're seeing, they're common themes that are coming through really. But even just 15 minutes, they are 15-minute sessions so that we're not disrupting days, but they're having a huge impact. And I've no doubt that, you know, with continuation of this, we will continue to do that. But thank you for that. It's appreciated.
Thank you, Chair.
Thank you. Lovely presentation, and really nice to hear you, this our colleagues' well-being. I suppose I just wanted to comment really. What struck me in your presentation and reading some of the materials, just a great bit of innovation here. And you know, it's worth noting, obviously, this has been sort of pump primed through charitable funding, so it's a really good example of how through different ways of working, we're able to bring something to our colleagues that might otherwise be out of our reach. And also, I love the volunteer component as well.
It's fabulous. Yeah.
That says something about people's commitment, but also the opportunity to perhaps give people some exposure in a different work setting that hopefully helps renew them.
Yeah. And we are finding that, and I think as well, because we're training our colleagues to do this, there's an upskilling element as well, so people are happy to learn a new skill. You know, the skills that are learning there are easily, they're applicable, and they're making a great difference. So I think it's got so many benefits on lots of levels. So for the people that are receiving complementary therapies, everybody that's involved in the training, and everybody that's involved at all levels, because when teams are requesting this, they're seeing a difference in the teams because the well-being is, you know, is better than what it was. Morale is higher, sickness and absence is lower. So there's benefits on so many levels.
And it's also accredited as well. She's not ashamed. That's not giving herself the credit for what she's actually delivering. So the training that she delivers for basic massage is certified and accredited for those volunteers that come and do the training sessions, which is also delivered once a month at every care block. So that's accessible to anybody that wants to participate in that, whether they want to do 24 hours to make a difference as part of the volunteer, or if they've got their manager's approval. With the test change that we've done, where we've gone in and done focused therapies within specific teams. So really arming our own staff to be able to sustain this in the future, because we do only have funding until summer next year. We're hoping that Charities Together will be able to support us again on a further bid. There's hopefully something coming out in the autumn that we can apply for, because absolutely we've collected the data and we're showing the impact that it's having. So yeah, we're really proud.
Thank you, Julie.
Thank you very much for that. And clearly, it is having an amazing impact on our colleagues, and also not only the recipient, but also those who are being trained as volunteers. Thank you. Really interesting illustration of putting into practice one of those really important values of ours: care. We care for each other, not just for our patients. So thank you very much indeed. Thank you.
Thank you. And should you wish to appreciate the offer even more, our lovely Sarah is here in the Mayo on level 2 once a month. So do tap in and actually, you know, feel the benefit for yourself. Thank you.
Thank you. Thank you very much indeed. Could we turn then to apologies for absence?
Certainly, Chairman, we have 4 apologies from Professor Helen Kendall, Jackie Royal, as Deputy Stu Lorimer, non-executive director, has given her apology, as Rachel Jones, non-executive director, and Mrs. Nikki Clark is also not with us today. Apologises for that. I've just spelled Carmichael as Deputy Chief of People with us today.
Thank you. Are there any declarations of interest? If not, can we turn to the minutes of the meeting held on the 1st of May? And can we accept those as a correct record, as a matter of fact? I'm interpreting nodding your head as out, sorry.
That's the mine one, Chair. In page 9, it says a non-executive director TC left the meeting. So I stuck it out.
Would you have liked Mylan?
Yeah.
Thank you. Can we turn then to matters arising? Please, and are there any matters which are not on that paper, as there are a number which are actually going to be considered on today's agenda? If not, can we accept those matters arising and how they're being attended to? Thank you. Let's continue then with the action tracker. And are there any matters from that action tracker that colleagues would want to raise? Silence, I think, means no. Given that, then, can we turn to the finance report of the agenda? And in Sue Lorimer's absence, Tim, would you like to take us through any matters which you want to bring to the board's attention, please?
Yes. There's minutes or AAA reports from 2 months. Just talk for the meeting last week, and see take questions. In terms of the alert, it's the financial position which the CFO will take us through in a month, but to that, it's the 20.5 million deficit, which is 1.5 million worse, which is accounted for by SIP's slippage. Also, in both months, we're reporting the capital position, which is important for the Finance Committee to keep tracking. And as it stands, we do have sufficient cash reserves. Other areas that are worth noting, we have made an amendment to the terms of reference in respect of reporting on estates and facilities. It's probably something for the board, not necessarily now, but it has come up at other committees last week around us reflecting on how estates and facilities are overseen by all the committees, because obviously there is some overlap between portfolios of execs, but it's probably one where we have got some gaps. But in terms of the Finance Committee taking a key role, that amendment has taken place. In terms of assurance, positive to make reference to our continuing grip and control, particularly in respect of agency spend, and the note there that we now have the lowest agency spend percentage in GM, which is I think important to comment on. The risk areas that are at the end, again, I think are worth noting for the board in terms of still awaiting decision on 26.3 million capital funding associated with the PAT transaction. Still the focus that we have, and we have that focus at board today on the gap between SIP target and planned schemes and high risk options, which we're looking at today, part of the committee's focus, and also to flag the issue around the 47 million shortfall on contract reconciliation, which is not included in our FSP, but we had an update at the committee, but it's important to flag to the board. So those were the main issues, particularly from the June meeting.
Thank you. Given that request from the Finance Committee to approve the change in the terms of reference of the committee, can we accept those changes? Again, lots of practice of nodding heads. Thank you for that. Can we turn then to the finance report for month 2? Craig.
Thank you, Chair. I mean, Tim's picked up a lot of the main points, but I'll just put some into context and then take any questions. So, as we've said, we're 1.5 million away from plan in month 2. That was against our original deficit plan we submitted in May. We know since then, from month 3 onwards, we'll have a revised deficit plan of 75.7 million, where we took boards through in an extraordinary session how that materialised. So we'll track against a new deficit position from month 3 onwards. In terms of this month, on the people side, to bring a bit more detail to that, we are tracking in line with our people plan at the beginning of the financial year. I do stress at the beginning. There has been some improvements. So we are in month 2, we're at 20,217 hold times. That is 402 hold time reduction from March 24 this year. So we have seen a material reduction in hold time equivalents, but as Tim alluded to, there are risks on the CIP programme, which means that we can't take it as far as we need to satisfy the CIP target at the moment, hence the gap that's being articulated in our plans. We have the £85.6 million CIP, and we have circa 56 million, including pipeline, against that non-risk adjusted at this moment in time for the latest position. That's not in this report, but that's the latest position that we have at the minute. We do have some schemes in play around high risk options that we will take through to part 2 of the board today to discuss plugging that gap, and also some further stretch in certain areas and functions that we've set targets for this week around trying to pull and stretch out what we currently have and convert that into recurrent. At the capital side, we know that, as Tim mentioned, that of our 70.7 million capital plan, circa 26 million of that is related to an NIQ transaction, and that's pending an answer at the minute with NHS England. So we do have a mind's eye on that at Capital Group, and we've highlighted it at Finance Committee as a potential risk. However, the cash situation, to end on the summary, runs at about 94 million in month 2. That's about 19.5 days trading in sort of that kind of language. And we all say at board, you know, if you're running below 10 days, that starts to you can raise some awareness, and certainly below 5 days, you're into territory of requesting cash. We're at 19.5 at this moment in time. That's all I want to say on that, Chair.
Colleagues. Jay?
Thank you, Chair. 2 points. Good to hear that the reduction in workforce is being monitored by executives. Good to know when that's going to be fed through to both the People and Electoral Committee and Finance Committee. I note the references in the report later on today from the national sustainability plan at the scale of workforce reduction required, and was to obligate that target really. My other point was about capital, and there was a point made at the last meeting of the Finance Committee that there appeared to be some staffing shortages in the capital team. I know it's not long since the committee meeting, but is there any update on how those are being addressed? Thank you.
In terms of the tracking of hold times, I think what we're trying to do in this report for the first time is show a plan for hold times for bank, in the actual position, the plan position on substantive banking agencies. So you'd see some of that detail coming through in this particular report, Jeff. But what we have said is that we need to translate that into a care org position as well, and a function position, to go into much more detail at Finance Committee, so we can see, although we might be on track overall against the trust, there will be some plans that are running above trend. So we need to understand that, focus our attention on those areas that are running. So I think more of the same, Jeff, in terms of bringing more detail to Finance Committee. In reference to the staffing shortages in the capital team, that was raised in the capital group and subsequently at Finance Committee for your awareness. And that the action behind that is to look at the priority of the work that we have and make sure that's aligned inextricably to the 70.7 million capital, because some of the context for that was that there were new schemes coming online that states and facilities were making reference to not being able to manage on top of the current workload. So that is an action that Capital Group will take to reprioritise, and then if there are still shortfalls after that exercise, we will escalate to Finance Committee, because we may need to consider extra resources through capital funding for staffing for states and facilities for certain priorities.
Owen, sorry.
Thanks, Craig. I'm reflecting on the annual plan that we've signed off as a board and thinking we don't see either through the finance report or the integrated performance report where we are on activity. And so we're looking at what we're spending, but not actually are we delivering the activity that we said we would against our plan, which might talk to some efficiency. If we're ahead of the plan, actually we're managing the money, you know, talk a little bit to our productivity organisation. I wonder whether between you and I, we just need to think about where do we see activity against the plan that we've signed off.
Yeah, I think that's a really good point, Judy. It's something that Sue and I discussed just this week in terms of making some better triangulations for our reporting, because of course we know we report activity, we know what that is, we report delivery, and we know we report the finance through here, but the connection of the dots is not quite there. And it has been born out of the change in the financial regime around what we're paid is not necessarily linked inextricably to activity anymore. But it certainly would help us explain our cost base and why and what's driving the costs. So I think that's a good point. We need to integrate that going forward.
Yeah, I just wanted to just take the opportunity, I think, just to thank colleagues, not just in this room, but much more widely, because if we think about where we sit now, particularly in the cost improvement planning, and for the avoidance of doubt, we've got a lot of work to do to get where we need to be. But if you think about the last 6 months of the calendar year, we managed to get to, I think it was 55 million, Craig. The third quarter, if we're at around 56 million, including pipeline, albeit when you apply the risk adjusted element, clearly that gets to a smaller figure. I still think, though, it's important for us as a board, not really for us, but for a lot of colleagues out there who are doing a lot of work around this, to make sure that we recognise to be in a position of 56 million, talking of that figure in the first quarter is very different to where we were in the first quarter of last year. I just think it's important, Chair, that as a board we communicate through this mechanism about our thanks to colleagues but we know we've got a lot of work to do to get to where we would need to be overall. Thank you, Chair.
Thank you. I think that's a excuse me, a really important point. That there's been this tremendous improvement in the past 12 months, and we are in a very, very good position to continue building upon the work towards increasing the towards improving the cost improvement programme. And I think in recognising and acknowledging the tremendous commitment of our colleagues who've had anything to do with this, it's a really important matter for us to do. And I think in addition, we've had raised the questions about workplace, when that might progress, and we've heard that we need much more kind of drilling down, and so the next move in relation to that is to focus upon the care organisation's position and actions in relation to the reduction of workforce number. And finally, the point was made that it may be necessary to make a case to the Finance Committee for extra resource in the capital programme. So it may be helpful to know if it's possible to give some kind of timeline as to when that might be the case.
So, Chair, we've committed an action for capital group next. Capital group, so that's the 17th this month. So that's when that action's coming back to review.
Thank you. Thank you. Rabina.
Thank you, Chair. Just wanted to build on Owen's comment earlier about how important it is to support our colleagues through this journey. It is one which is very demanding, very time consuming, resource intensive, and at the same time doesn't often deliver in the timeline you'd want to, benefits that we see. So in the spirit of that context, just wanted to know what else we can do to help our colleagues running those departments who are not able to adhere to their own budget controls at the moment. You mentioned possible inconsistencies. So what else can we do differently to support them, to ensure that we have greater adherence to budget control and understand the granular nature of the data that we receive at board level to support some of the mechanisms and strategies that you're going to put in place for you?
I think that the main priority for this is to align everybody onto the necessary focus areas. And we talk at board around knowing the pay bill inside out and understanding how we can seek for opportunities and support each other across the Northern Carolines rather than in pockets. So we have committed to, as Jeff challenged earlier, to provide better insight, better quality reporting around the workforce movements and numbers across care roles and functions, and also to triangulate that with some of the vacancy control processes that we have in place to understand if there are any opportunities through redesign rather than replacing posts. So there is an opportunity there for us to learn lessons and to focus together on pay information. Equally, we've now started adding the whole time target, if you will, to the eHub system and reporting on what, in terms of our CIP, is related to pay, not only from a pound point of view, but now a whole-time equivalence point of view, because we need to understand that we're getting to the right kind of scale of planning to achieve what we meant to achieve from a pounds point of view. And I think that has been opaque compared to what it needs to be going forward at a trust level. So I think some of those things we can do to support, bring in line the context of what we're doing, and equally at the same time learn from each other on some of that, and filter some of that through the change portfolio board, because those are some of the major change programs where you want to be talking that through and understanding it at an NCA level.
Lorna.
So I just wanted to elaborate a bit further on what Craig said in answer to Ravina's question. So if you look at the governance regime that we have been moving into, we've now got cost improvement regime of programmes that really helps us hold ourselves to account and actually brings additional colleagues into the fold. So that's attended by not only care organisation, but many of our broader colleagues. When you then look across that filters down into each department area. We can see that there are regular sessions about cost improvement happening now across this organisation with different levels of leadership, attention and behaviour. We've got demonstrated change that happens as a result of grid and control. Agency spend is a brilliant example of that, where actually scrutiny and understanding and really looking in detail about behaviour and patterns really has made a material change. If you then look further in terms of, we've got a change portfolio board, which again brings further attention to real big programs of work and change related to our financial sustainability plan, but also really helps us bring that focus. And for me, that really ties some of the links about performance and planning through to financial controls and better granularity. And evidence really tells us that when we pay attention and look at our budget and our controls, we start to see material shift in behaviour. And actually that's a cultural journey as well for us in terms of how our colleagues at every level start to understand their budgets. And for me, I can see that really demonstrates that some of the behaviours that we're exhibiting really are filtering across the organisation and are not just top-led, they're across the piece.
If there are no other comments or questions, can we accept the place where we are and how there is continual focus on that, and in particular the kind of narrative which Lorna's just given us, showing how the focus on cost improvement goes throughout the organisation. It's not just top down, it is very much embedded in the behaviour of our colleagues. So, thank you very much for that contribution, Lorna. Can we then move on to quality and performance? Ravina, would you like to start, and then perhaps Tim could come in relation to the meeting that you chair?
Thank you, Chair. Can I just make a note of thanks to Tim for covering my new lead on the team. So, today the papers have been there with some specific highlights from the May 24th QPC meeting. The perinatal report was, of course, with 3 still notes, one at 37 weeks, another at 27 weeks, and they include termination due to severe cardiac abnormalities at 24 weeks. Each case has been thoroughly reviewed and appropriate. There's an improved on compliance in the fetal anatomy, screening timeframes, again addressed within the committee robustly. A new action plan is in place and is being addressed by screening software. Within paediatric audiology, an expert review, regular failings in paediatric and audiology services, which delays the identification and treatment of hearing loss in children. And whilst our trust was not directly involved, we are reviewing the documentation to ensure high standards are maintained. With regards to the quality dashboard, and some of this information again is within the integrated performance report that we'll see later or speak to later. An increase in healthcare acquiring veterans. We're working on improving infection control practices across the board, but this is something that we need to continue to be observant of. Within plant care and gynecology, particularly in complex gynecology and endometriosis at Oldham, we're noted. We're also addressing consultant management of waiting lists to ensure better efficiency. So in this report, we'd like the board to note and to monitor a thorough review and action plans related to stillbirths, and further improvements needed in fetal anatomy to greening compliance and ongoing efforts to reduce health-acquired infections and management of improved and wait times. Regarding the June quality care quality reports committee, Tim, do you want to make some observations?
Yes, just quickly. Jude, our Chief Delivery Officer, gave some important updates regarding urgent care and planned care, particularly in respect of urgent care being off track against trajectory. And one of the actions the committee agreed was to have monthly updates rather than the current bi-monthly updates given during the position. One area to flag is, it is in relation to sustainability. We do not have a sustainability lead. That is quite a gap for us as an organisation and a board. So Jude kind of set out the context to that, but it probably does signal how we provide a solution to that, and perhaps reflect again how the board gives oversight to that agenda and the governance around it. We did look at falls, nutrition, hydration, infections kind of came together in a discussion, and we recommended, I think particularly Aziz pressed on that, and a deep dive is going to take place. There does seem to be some context around culture that brings those together. Probably that's the main issues. It's a new IPR report to the board today. It's probably important to flag that is coming straight to the board without scrutiny at other committees. So it's for us as a board to look at that afresh and what that shows us, for us to kind of review that over the next few months. Positive, very positive in regard of freedom to speak up arrangements and how those are developing. And just one flag which comes up elsewhere, internal audit actions, and that there's a pattern that has appeared for a time where timeframes are getting extended. So clearly we need to look at the process, the capacity kind of around that, because it's kind of a persistent issue and it's flagged elsewhere. So those were the main headlines from the June meeting.
Thank you. I see Aziz.
Yes, thanks.
Thanks,
Tim and Rubina. I attended both those meetings, and I just wanted to put a little bit of flesh on, my concerns at having been at both those meetings and listening to Jude talk about, our financial performance and actually how they're connected to activity. Well, how is it connected to outcomes as well? And I think the board, I just wanted to make everyone aware that, there have been a steady increase in fall for the last 6 months. This is a pattern that are cause for concern. In Salford Royal, 5.7% of patient hip fractures are due to hospital falls. That is twice the national average. The requirement for medical assessment within 30 minutes of falls is nationally 74%, but the NCA is 29%. So we're falling far behind that. There's also been a steady monthly increase in infections. That's, I think, also about 6 months, wasn't it? And the NCA now is in the bottom quartile in terms of performance. And, we used to be at the top quartile. So I think, and there may be no connection between these two things. However, we are celebrating, or we're saying it's great, the fact that our agency spend is 1.3% of the pay bill against a national ask of 3.2%. But, our staff consistently telling us that they're under pressure. So, where is the balance here? Are we getting it right? And I just thought it was worth putting that point in along with all the others where we talk about activity and financial.
Thank you. Jackie and/or Jude, would you like to respond to those 2 points, please?
Can everybody hear me?
No, I think my red's on. Keep going.
Okay, go on.
We have recognised that if we see a statistical increase in falls in the next month in our data, that is a statistical increase overall. So we have already, as Aziz refers to, started to look at why that is. If I relate it to the staffing comment that you made, we have a safer staffing, and all of that is coming through our assurance processes that indicates that we're in the top quartile for care hours per patient per day. So we're in the top 25% nationally of organisations in terms of the amount of staff that are available to care for our patients. So we do know that we have a very good fill rate for our nursing staff, and we also know that our nursing staff particularly are those that we employ and train ourselves. So whilst our staff consistently tell us that they are under pressure, absolutely. What I do feel more assured about is using our own staff in bank is better than employing agency staff where we haven't trained them and developed them in our own way. I don't want to comment on why we are seeing an increase in our falls, nutrition and hydration incidents and others until we've done the deep dive. But certainly from a staffing point of view, if I compare ourselves to 2 years ago, our staffing fill rate is vastly different. We were 80% lower than that, but we're now consistently above 90.
Okay.
Jude, would you like?
He's wanted to follow, Chair.
I hear what you're saying about the hours per patient care per day. However, in every report I've sat in Quality and Performance Committee, the NCA has been below the 90% nurse fill rate. Are you telling me that's now above that? Because that is a combination of nurses and healthcare assistants, the figures you're quoting. And in the past, at Quality Performance Committee, when I've said to the chief nurse, is there a harm associated with the fact that we are consistently below the 90% fill rate? We've always pointed to the figures where actually there wasn't. You couldn't see an increase in falls, an increase in infections, worse nutrition, hydration. That's changing. That's changed over the last 6 months. And there's a difference between nurse fill rates and hours per patient looked after, because that's about healthcare assistance. Are you telling me we're now above the 90% fill rate for nurse? That is the nationally requested? Because we haven't been in the past, Jackie.
Let me go back and check the data, Aziz, but I am reasonably confident that for the last month the organisation was above 90% fill rate.
Thanks, Chair. Yeah, I think just a couple of points. I'm right, Judy. Just verify this. So I think the report on the 24th of June was talking about our 78-week waiting. There's 14 outstanding. I think what we're probably now at this week is understanding that by month end it will have been about 8.
Correct.
Around that. I can't quite remember where we were this time last year. And I know that we've set ourselves 0 as a target, but I'm pretty confident that the 8 that we remain, some of that will be about patient choice and also about clinical availability. So again, I think it's just something about making sure we understand that. So if you could just clarify that. The other thing that I think is in relation to the 78% target. So we're 13% off at this moment in time. Certainly in conversations that Jude and I have been having, I think it's really important that whilst that 78% is clearly where we're going, and we have to demonstrate continuous improvement against that. It's not good enough to just be standing still or whatever else. So we know we've got work to do around some of that. But I think there are some subcategories within that that we do definitely need to make sure we pay attention to. So corridor care, we want that at 0, that is humanly possible. And certainly 12 hours decision to commit are a couple of areas that sit within that because they do talk to patient experience. We will be, redoubling our efforts as we slowly try to improve and get to the 78%. But I think there are some sub-quality indicators that we need to make sure that we continue to pay attention to, Chair, and that's what I wanted to make sure that the board understands that is in our mind.
Thank you. Those are really important matters that you were asking there. They are about experience, patient experience. Carmen.
Thank you. I noticed that the minutes from the or the notes from the June meeting, it refers to a risk about in endoscopy and lots by consultants, which seems like a huge number. We've requested mutual aid, but it doesn't tell me whether or not that mutual aid has been forthcoming or we have any indication it will be forthcoming, whether that is still a risk.
Yes, so we haven't cemented a mutual aid yet. There is a push this through for that, and it is Thames that we're looking at. Chief Operating Officers in contact with my deputy about that. That request has been made. We have got some insourcing in the meantime, so we are using our insourcing company to bridge some of those gaps pending the recruitment. And I know Rafiq probably wants to come in on some of the more sustainable solutions to that 5 gap. Thank you.
So just to add to what Jude said, we are going through a recruitment process to replace those colleagues. We're also linking up our colleagues here at Salford with our colleagues at Oldham to try and improve some of the cooperation and cover. We've covered part of that gap with new appointees, but there's just a bit of a lag time in terms of people starting. We will still have, I think, just over 2 whole-time equivalent gaps in there that will need to be covered as we go forward.
Thank you.
Jeff.
That's it. I think we should get to 0 levels of corridor care. During corridors in any games that I mentioned before Christmas. It'd be good to understand how ethically meeting how we measure progress towards that target and the time we think about it to get that position. How realistic is that in the medium term? Thank you.
Jude. Yeah, I'll pick that up now, actually. So Owen's right. I think there are, whilst the absolute target of 4 hours is important and will continue through our urgent emergency care improvement months to drive towards that, there are a series of important quality and safety indicators I think needs to pay attention to. So I would add onto that really the appearances about our CQC must and should do. So it's particularly important for Salford Care Organisation in terms of the CQC rating that we need to ensure that we've got those assurances, the ambulance handovers, the patients in the department. 12 hours we know from good data that there is a higher associated mortality rate age 12 and beyond 12. And finally, that elimination of problem care in our urgent and emergency care programme. We've set an ambition for that to be eliminated by October. It is associated with also some financial benefits because we pay nurses and support workers to staff corridors. So It's also reflected in our financial plans. We have got action both on the demand side through the ambulance conveyance work, and on the below and hospital discharge side, so they're dedicated away from dementia work to support the elimination of that care, as well as NHS and our frailty units. So there's something about what's the corridor care is the measure, the improvement action that sits in the side of that in terms of capacity and demand, and those are reflected in that urgent care plan that I suggested we see at the quality committee. In addition to that, we have established a full locality partnership urgent and emergency care improvement group. So where all the localities will come together. Some of these actually sit within localities in order to support us. And that meets the first time, I think, I'm going to say we have the next. And there's something, I think, for us in that form, in addition to the work that we are doing in the organisation, to look at how we're using the better care in order to support some of those actions. So October, as we head into winter, what we have in mind, want to make the distinction in corridor care between fit to sit, which is a national emergency department sort of narrative where patients been seen in a cubicle. I can sit them outside while we work bloods up or do next investigations, and you might use that cubicle to see and assess and treat somebody else, as opposed to what we are seeing, which is patients being treated in that assessment using it almost like a cubicle. I think there's an important distinction from that.
Thank you. Are there any further comments before I draw together what I think is a really important part of the board's focus in the next, well, for the rest of the financial year, I think, but certainly before winter pressures become really apparent, and that's through the focus at Q&P on monthly updates to improvement programme. There is an opportunity to focus on and therefore give the board assurance on the actions in relation to corridor care, and there is a distinction between that and fit to sit, and it is corridor care to which the intention is to eliminate that by October. That there are other quality indicators in relation to that quality, in relation to corridor care, which include the ambulance handover, and the better use of the better care fund. So that those are some of the areas in which the board really needs an important focus if we are to ensure that any harm resulting from 12-hour waits is minimised, and that there are also financial reasons to eliminate corridor care, as we are in order to staff that, we have to find an extra resource. Are there any other comments that matters that I've missed in relation to that? Are colleagues satisfied that gives an increased focus on these matters, these quality matters? If so, can we turn then to the maternity leave? Would you like to introduce that, Jackie, please?
I believe we have Faith underneath it in the room. So thank you very much for attending. You can see that we've got a maternity services report along with a number of appendices. One of the appendices is for information, which is the GM advice around board reports for maternity services, which they would like us to consider altering the report that you receive here in order to demonstrate a number of the outcomes and indicators that are captured within that report. So Faith, along with myself and others and a team, will be working to amend the report in the next couple of months to reflect what we've been asked to.
Thank you.
Our report this month also includes reference to the assessment and accreditation service that's happening in maternity, and our assessments that are underway. We've recently had a reassessment. I'll let Faith, I'll not steal about that, but to give some narrative there, assessment and accreditation for maternity services is very, very new. It's fundamental standards. Outcomes for women and their babies are monitored intensively in maternity services, but fundamental accreditation services are not common. So I believe we are one of the first, if not the first, to go nationally with this type of bespoke accreditation system, and we are pleased to say that it is already appearing to have the results that it's intended. So we will find that detailed in the paper, along with our usual indicators and other risks and issues.
Thank you. And just to remind colleagues that the papers have all been read, so we can probably go straight into questions.
Yeah, absolutely. There are just some elements of the paper that are follow-ups from previous discussions and actions from previous discussions. So happy to take any questions about those.
Carmen? Oh, sorry. Wasn't clear.
Yeah, thank you. Thanks for the report and read with interest. Just on the point that Jackie raised on the maternity assessment and accreditation process, which sounds an excellent way to proceed in terms of the integrity of the service. I'm just wondering whether there might be more coming back next time or in a different place. I've found it kind of quite light on where it's headed, and then behind that what the standards are, because it's good to have that focus and say, right, yeah, we're red in these areas, and one can see that there's been progress. But I guess if it's a known set of standards and it refers to action plans, then maybe just a simple column of when are they all expected to be green by, because the action plan would be planning to get them to the green standard, and because it's in the area of maternity, and I guess you just look at patient safety red. You look at things like safety and risk management red, and you want to know by what date those might turn green. The one other thing was it referred to certain areas. Some areas have been assessed and one area had been re-accredited, but just looking at the presentation here on the tables, because there's just one set, you don't know which area that is unless I'm missing something. Thanks.
Yeah, absolutely. And I think what's happened, we started in April 2024 with all of the areas within maternity services being accredited as a bit of a line in the sand, really. Where are we now? Let's benchmark ourselves. Where are the improvements? So all the ward managers have implemented, as you quite rightly say, action plans on the back of those, with those trajectories for compliance. The only service that has been re-accredited is the antenatal ward. So obviously, as the rest of the areas start to go through that second validation, we would hope that they would also have more areas moving towards those green standards. But yeah, absolutely, there is a clear trajectory. We are working to timescales. So within the next 6 months, we would expect to see significant improvement with much more green compliance. I think there is an overall trajectory, isn't there, Jackie, for the whole of the organisation to reach green, which we shared at QPC last week. So I'll just bring Jackie on in terms of that overall, because we have seen significant changes across the whole of the organisation with those scores.
Yeah, the trajectory is to have no red areas by April of next year and all areas to be green by December of next year. So that's 2025, based on the reassessment process.
Thank you. Chris?
Yes, okay, thank you. I just want to say something about the asking the paper about the digital support. I think we probably missed that at Q&P as this paper came through. So a couple of things for me. Just I guess in support of Lorna and our digital colleagues, we've got any number of asks that are coming across the organisation. So, you know, we have, you know, some big programmes in itself, a commitment to NEPR, but also we have some significant transformation programmes, and Lorna and I met last night, even to look at the programmes which I've got responsibility urgent care save patients, and a number of requirements around digital system solutions that help us deliver some of that efficiency, that take people out of the process and help it get driven in a different way. But there is work for us to be done, I think, to look at the totality of the asks of the digital team rather than look at that in individual areas, and to look at the resource that Lorna and the team have got and set some priorities. So I just wanted to say that rather than just sit there, that there's work for us to do to support Lorna's team in agreeing some priorities. That said, I think it's a question because I am not familiar with Badgernet as a system. But if I think about pathways of care, and actually along pathways of care within digital systems, you can often set standards in there. You can do things that people can or can't do within the digital system, or questions they may need to have to answer as they're going through a particular process. And I'm not sure whether Badgernet has that kind of functionality. So when I look at induction of labour audits and I think about caesarean sections that are done at less than 39 weeks, Faith, I don't know whether there is an opportunity to use Badgernet, develop pathways of care within Badgernet that stop us. You know, our action plans are always very much ward managers will remind people to, or, you know, we'll audit it and then go back and, you know, set a paper process to help drive the delivery of the change that we're looking for. And I don't think Badgernet helps us to do some of that.
I think some of the challenge is at this present moment in time, we're not entirely au fait with its full capability. Okay. We have really good support in terms of our digital midwives, our lead midwives. Lorna, we do get support from the digital team. It's not that we haven't got the support. I think the issue is in many of the cases is that System C, who hold the system in its entirety, have a pre-built system, and it's very hard to make changes unless they're then national changes. And it's about what support can the digital team give to us to assist us in that escalation. I think the other thing is around all the team understanding its capability, and whilst it still feels in many ways we're still in that implementation phase, which is perfectly normal, it's that next stage and how we get to that next stage, because I do believe it can do those things, June. You just don't know what buttons to press to get to them.
Lorna. That's all right.
You sure? So I do know that what Jude just said and what Faith has said. I think this is a great example actually for us all, that implementing a digital system doesn't immediately address long-term sustainable process change or behaviour change or understanding about service. It helps shine a light on things and it brings things to the fore. But I fundamentally agree with Faith that we implemented essentially an electronic patient record for maternity. We are absolutely still in implementation and then to move it to optimisation. And if I look at where we came from a maternity services point of view, we've also been learning and changing how we provide that service and functionality, bringing in new leadership, bringing in changes to girl. That in itself will fundamentally change what we set out to ask an EPR to do on day one to where we are now, we're maturing. So it's entirely sensible that we continue to evolve that. The other key thing for us is that one of the benefits of taking an electronic patient record system that is more fixed is that it does allow us to conform to national standards. It does allow us to adopt what's good practice and best practice rather than trying to bespoke something special to us and make ourselves different, which actually brings a further overhead and further risk. So it is an evolution in terms of where we are. And absolutely, I think the maternity team have done some great work in terms of really focusing on digital midwifery services and thinking about how you build that skill and capability into the team itself, because that's what makes the fundamental difference in terms of system adoption. And absolutely, we need to work with our providers to really strengthen that and understand. But we should try and shy away from trying to make heavy config change that makes us special or different, and really adhere to what a national adoption looks like, because that's where we'll get true value, and that's where we'll get improved safety, understanding, and improved controls.
Thank you. Chris, thank you. Just a view from my visits, if that's of interest. Firstly, the maternity programme board has changed and is now chaired by Armistead, who's a former chief nurse and deputy chief exec, and I think is known to you all, who I think is going to be a very effective chair going forward. So that's a very positive change, I think. From a visit, personal visit, there are a few areas. One concern was raised about the level of normal births. That's been a consistent issue on 2 visits, and you'll see that there is a report here, induction. It was a concern expressed by quite a junior members. And I've spoken to Beth this morning, and we'll go back to the member staff with audit results. But I think it's something that we ought to keep a watch on, because I think that there is, I think that one of my previous visits, a senior midwife said that it was only about 15% of births that were completely without any intervention whatsoever, which is extremely low. And it's something that I think we need to keep a watchful brief on. There is an issue around interpreters. As I listen to the PPEG, which is the Patient Experience Group, it's something that I've asked audit, in our internal audit, to review, because I think it goes to the very heart of experience, and particularly safety for non-English speaking moms. So I think that's something that we should continue to keep a focus on. My concerns this time from my visit are mainly around accommodation, the states, and there were 3 main areas. One is the triage changes in accommodation, which were referred to by the CQC, so it goes back some considerable, but are still not completed. We're still waiting for pane and glass. We've got a door fix that doesn't work properly. So there are issues still around those accommodation changes. There has been a serious leak in that area, which involves sewage, and I've seen the photographs, and that was extremely grim issue for our colleagues to have to deal with. And there is not assurance that this won't reoccur, and that's a particularly dangerous situation, I think, for mums and babies. So I think we need to hear that problem is not going to reoccur. So that's not something that the midwives in that area are really, really worried about. So I think we need to follow that through. And the third thing is around signage. It's something that I raised about a year ago. It's something that there's a reason quite often why we don't change signage, because it's going to be part of a larger reconfiguration. But in the meantime, we have women who may be appearing in labour or losing blood, who are walking up and down corridors and don't know where to go. And we've been told that it will be redone on a temporary basis, and that hasn't happened. And so I'm raising it, and I promised midwives that I would raise it here today,
because they feel as though enough is enough. So the theme from my visit this time has been around accommodation, and so those are the issues that I said that I would raise on their behalf that we can follow through. I think that's about it. Thank you.
Thank you. Those are matters which I think we cannot ignore, and indeed the sewage incident is very, very important, and not only do we need to get some assurance about when that will be done, but it needs to be done yesterday rather than today. So can I emphasise that that's a really urgent action from this meeting, and those other two matters relating to signage are also of major significance, and it's really important that these matters are tended to, and that where these things are at is brought to the attention of the chair of Q and P, quality and performance. Owen. Great.
Yeah, I was just going to comment on the new formats that Jackie mentioned on the report, because I think for me, what the new format does, or the suggested format, does bring together a collection of issues, because we've talked about staffing issues in maternity. We've done some investment into establishments, let's say, because we know that we've constantly grappled with recruitment in particular areas. And I know, Faith, you've brought reports back to us to explain where that's up to. But I think we lose the thread of it sometimes at board about where that's up to. So I think this brings that together and speaks to some of the points Joe was making earlier then, to focus on the future and then what by when. Because what I think we'd be interested in as a board is to see what the limiting factors are and how that triangulates to some of the risks, because staffing might quite quickly become triangulated to a number of risks, but I can't quite see that connection yet. So I'd hope we take this opportunity from this format to try and link some of those things through, to bring that through to board so we can look at the appropriate actions to take, and it's not, it's all in one place, and it's harnessing what you want us to listen to around what you believe is going to be a limiting factor to deliver some of these things. Because we know we've made improvements, we've had rebates on CNST insurance, so that's definitely improving. But I think this report, we should sort of embrace it and use that as an opportunity to really get to those gritty issues that we need to see at board and hear about so we can support.
Yeah, I agree, Craig. I think it is an opportunity to revisit the literature that comes to board in a format that gives you the same information month on month, but you can see those improvements in that thread.
It was just to say in respect to the items that Chris Mayer's raised. If I could just ask Craig, working with the Dean and also then with Faith, make sure. I suspect the signage one might not be as straightforward, but I think the two elements that you referenced, and if we can make sure that Chris by a week Friday has clarity about when those issues are going to be tended to, so that feedback can be given by Chris to those colleagues. Thank you.
Thank you. Are there any further questions from colleagues? Ravina.
Thank you, Chair. Firstly, thank you, Chris, for raising the matters that are extremely important to address, and I'm glad they're going to be escalated. But going back to the patient feedback as well as colleague feedback, I think there needs to be more evidence in the reports of how the feedback has been integrated into our improvement plan. So we take the interpreter challenge and widen that to how that improves or depletes a positive or poor experience for mothers in the hospital, that can be very damaging if the concerns have already been raised or been asked for feedback and hasn't been implemented. That doesn't look very good, is it? I know that you worked really hard in the team to address some of the feedback and implement it, but I think it needs to be further strengthened. Going back to the new model of reporting, I think there's something there about data accuracy and where data is collected. If you want to validate information, has to be contextualised in the way that Colin already mentioned. There's also something about understand how the protocol takes place. But in the main report, we do want to have some more information on governance addressing the blood sampling errors. So I'd like to say something about that, and I have a couple more comments to make.
Yes, so in terms of the blood sampling errors, whilst the numbers are still small and have reduced, what we have noted, and it talks slightly to Chris's part around that triage stage, we have seen an increase in blood sampling errors in the triage department. So whilst everywhere else is reduced, that area hasn't followed the same trend. And some of that is around the estate. So within that area, there's a number of services that are working out of it, where there's limited computers because they're looking to use the same piece of information. So they're not following the patient identification process in its entirety. So what we've observed from doing the audits and observing care is that they will go to the woman, take the blood, then come back to the desk, print out the form and write on the bottle, which is absolutely not the way that we should be doing it. So we are trying to expedite the moves within that area to have triage as a completely separate entity where they've got their own dedicated office space, desk area, etc. Because then we can embed what good does look like and make sure that they are compliant with it. The main risk obviously is around group and save samples. So we have a process now where the laboratory are reporting it and we're also reporting it to make sure that we are thoroughly investigating all of the wrong blood in tubes that occur. So there's that dual process. And the laboratory staff, I have to say, have been very supportive in that education and training and review of those incidents that have occurred.
Thank you. Can we have a further update please?
Of course.
Thank you very much. Then there's a further question I had around there is increase in respiratory related admissions. So what do we know about why that's happening and how are we addressing that?
So I think I'll speak from a maternity perspective and then bring Anita in from a neonatal perspective. And obviously we do work closely. So all babies that are transferred to the neonatal unit, particularly at term, have that joint review on a weekly basis. So what we're looking for is there anything that we could have done differently? And that process is what initially highlighted was the concern that we had around the babies being born by caesarean section under 39 weeks. Because what we know from evidence is that if babies are born by caesarean section at below 39 weeks, the risk of them developing respiratory distress is increased due to their lung maturity. So initially that was that piece of work that we started to do, and we've seen some real successes with that. Within the reduction of those babies that are being admitted. What we do still have though is a certain number of babies that are admitted with respiratory distress. And as an organisation, as a team and a governance process, we need to make sure that we've done everything that we possibly can to avoid it. There will always be cases where babies are transferred that are completely unavoidable, but it's the ones that we can avoid by keeping babies warm, making sure that they're fed, in order to reduce that transmission. I'll just bring Anita in from a neonatal perspective.
So yeah, we have put pathways for care for these babies because we know that when they're born by C-section, they have an increased risk of developing respiratory distress and therefore being admitted to the neonatal unit. So we developed a short observation pathway where babies can be observed in the first 4 hours and only admit if they persist. So that did bring our rates down, but in the recent months, I think there is an upward trend. So we need to look into it further, and I'm happy to bring back our interventions for that in a later.
Thank you very much for that. think the question that's kind of presenting itself to me is around how we're triangulating what we're getting from our audits, particularly around adherence to C-section of appropriate time, and when they are delayed. I was wondering whether there's some kind of interconnection there with babies, at the increasing number of babies, we're then seeing.
So these are meetings that happened every week, so that's where we discuss these. We also get data from the next dashboards, and where they monitor our term admissions and late admissions. Actually, we were in a good position so far, but as I said, in the recent months, there has been slight increase, and we need more data to look into that, to bring more interventions in these. So I'll bring back some.
I would appreciate that to KPC.
And I think in the last quarter within the report, there were 9 or 10 admissions to the neonatal unit that we thought were unavoidable. The majority of those weren't for RDS. They were for other reasons such as hypoglycemia and low temperatures. But absolutely, we need to make sure that we are following guidance, particularly around that cesarean section at less than 39 weeks, to ensure that we're not admitting more babies than we need to, and that we're not increasing the risk by not following. We've absolutely got to continue to triangulate that in our meetings.
Is there something then around behaviour patterning, adherence to guidance? Because Chris mentioned in that colleague about the infliction of labour, and that the inductions were carried outside of the guidelines. So I think we just need to have further assurance that we are putting in people's pressures around the training, development, accreditation of our colleagues who are working in this area. So it's challenging environment. I predominantly do a wonderful job, but when we slip, when we see emerging trends, we need to be mindful that they can develop into harm, and that's something that we really want to think about very carefully. So again, if I can come back to QPC.
Could I suggest that some of these matters are picked up at QPC?
I just said that.
Sorry. Could I just draw this to a close then? And I think important things to come out of this are the emphasis on triangulation as evidenced through the support given for the new reporting format. That the matters which have been raised by Chris have been escalated, and we have a way forward to addressing them. And finally, can we assure ourselves that we've considered all the matters which have been listed in this? These recommendations suggested. Thank you. Thank you very much indeed for your attendance and contribution. Can we continue then with people in education? Disease.
Thank you, Chair. I'll take both the AAA reports as read. I think it's interesting to connect two of the alerts from month. So in May, we were saying it was highlighted to the committee that only 17% of medical leaders had attended the Advanced Leadership Development Programme, and only 48% of Band AC and above had attended ALDP. And it was agreed that more attention needed to be done to ensure that especially our clinical leaders attend this programme. We can move into a clinical leadership model. Then you move forward to June, and the alert says, following various updates in the committee, it's been acknowledged that managers are unaware of their responsibilities. And it would seem that, there's a bit of triangulation between those two. And Heather in particular was focusing on this. And as a result, a number of actions were agreed that, communications plan developed the next 2 to 3 months, in which key messages aligned to people policies delivered by a team talk and effectiveness framework to be developed. And Heather also said actually she felt that we needed an internal audit plan here to be looking at managers and their responsibilities and whether they were aware of them. I thought it's, we do need the higher bands and our clinical leaders to be going through the advanced leadership development program. I think that's, it seems to me, when I was out, so both Carmen and I attended that 2-day course, and a lot of the people on it were junior people. There were some consultants on the course as well, but it seemed that the managers seem to be sending people who, of course, we want to develop our lower grade staff, but the senior grade staff don't seem to think this pertains to them. And I just think there needs to be some sort of shift to help them understand that, leadership development, continuous development is for everyone. That is, what all organisations do. I think the other thing worth pointing out is the e-rostering programme. That's now complete for non-medical staff. It is now moving into clinical and medical staff, and it's going to meet resistance, I think. I mean, sitting in the Junior Doctors Forum, Ravik, it was quite clear that they didn't have much time for this. So it is going to be rolled out, and I think be prepared for some difficulty in medical staff accepting the e-rostering. And the other thing is about sickness. So, when you look at this snapshot from month to month, it just seemed like a small rise, about static. But actually, when you look at that integrated performance card, and people committee comes before policy performance committee. So when I sat in policy performance committee, suddenly you saw this 6-month trend of an increase in sickness. And this is not normally the time of year when we see an increase in sickness. 6 months increase means since December. So I think that's, a cause for concern, and it's certainly something that, people committee were looking at, and that Heather was also going to. Thank you, Chair.
Thank you. Really just to follow up, Aziz, on the point you're making about senior leaders, particularly looking at potentially the clinically led model, and whether or not it ought to be made compulsory for senior leaders who want to have a role within a clinically led model, that need to understand what their role consists of, what sort of leadership we're looking for as an organisation, which would then prepare them for contributing towards the creation of a clinical led model, rather than create the model and hopefully we've got people that are willing to play their part. And so I think we've got the chicken and egg here. So my view would be that we should be making this compulsory for people to be parts in this creation of the future. Owen.
Thank you. So first of all, there's a planning reality. It is easier for me to plan to take 2 days than it is for a clinical colleague. So whilst I hear about the potential around the nature of it, I think there's a thing about it. Let's make sure that we understand that for a clinical colleague to sign 2 days back to back is not straightforward as it would be for myself. And I suspect every single colleague here who's an executive has actually been on the Accelerated Leadership Development Programme. So there's no doubt there's commitment, but I think Kristen's also the question about making it compulsory. The sentiment's right, but I think in doing that we also have to listen to the feedback from clinical colleagues about forever being asked to do training which forever becomes compulsory, and that compulsory list gets longer. So what we've got to be able to determine is what on the existing compulsory list might we say is no longer compulsory, and if we're going to prioritise it accordingly. But I think to add will probably run the risk of actually making colleagues feel less likely to get involved. So we'll just need to think through that. But I think there has been a consistent thought that, of course, we want to get more colleagues, if we can, who are practicing clinicians doing this work. But by the way, there are a lot of them. And I think we need to make sure that we're not making distinctions about medics without recognising the broader church of colleagues who I do know attend that course. Certainly they were a broader church of people who have direct patient or client user contact. So we need to do that. A little bit that kind of, it's just a perspective I have. I don't necessarily, no, not necessarily, let's be candid, I do not accord hierarchical position with leadership. So actually, it's more the merrier for me. And yes, of course, those people in senior positions, if we can get them there, whether they're clinical or managerial, great. But actually, it's the broad church of leadership that I think is really, really important. And I also think actually the follow-up to the Accelerated Leadership Development Programme is just as important. And I think that there is an area there that we need to do and we need to follow up on. But the basic tenet about if we are committed to a clinical leadership model, tools like the Accelerated Leadership Development Programme are essential to actually make that is a correct thought process. And I'm really clear, and again, will restate, there's a stop-go moment for me in relation to the clinical leadership model, and it goes back to what Chris said at a discussion we had previously about learning from past history. It's really, really important for me that we do not progress the clinical leadership model. We've satisfied ourselves that we've got a pool of leadership that can actually adopt and develop this model and take it forward. And that's not just at its implementation stage, it's for the years thereafter. What is the ongoing leadership pattern? And, we'll surely maybe discuss this a little bit later, maybe it's part of the change portfolio board discussion. But what we haven't got the sight on at the moment is what does that look like? And how are we going to make the time for these colleagues to be able to do that leadership development? But I would say, I reiterate again, for the board's attention, if a stop-go moment for me, I would not be sanctioning or recommending that we adopt a clinical leadership model until we have got clarity about how that actual leadership and development, because we are not going to make the mistake of putting people into roles and asking them to do things without having the requisite leadership training and development. So that was kind of on that point. The other point about the about sickness absence, and so when you do look at the integrated report, I think that there's just a danger about fault assurance, isn't there? Because when you look at the data in aggregate, you get one picture. But I think, and I don't know if people in education committee really delve in this, but what does that look like in terms of hotspots, where it's a 20% or 25%, and is there a focus in that? And it's an open question. I should know the answer, but I think there is something about. It's good when I see the trend about that, but I'd like to see that trend in some of the historical hotspots. And I think that's maybe just a piece of work that we want to do. It's not really a comment to you, Aziz. I think it's a comment more generally that I'm making. Thank you, Chair.
Thank you. Rafi.
Thank you, Chair. So a couple of comments around this. I think the Accelerated Leadership Development Programme is key for our medics. Speaking about them specifically rather than excluding other groups. It is key for the clinical leadership model, as Owen has pointed out, and as he was sort of challenging us on. And the current phasing of the clinical leadership model is that there is a specific phase 2A, if you want the numbering, that specifically looks at the development of clinical leaders in the wider sense, to ensure that we have a cohort of colleagues who are able to take on responsibilities, and that we have an ongoing process of a pipeline, so to speak, that allows us to succession plan from that perspective. Medical colleagues have
masses of mandatory training that we have them to do. At last count, it was over 80 hours that we're expecting them to do every year, in addition to other continuous professional development, etc. We are looking at rationalizing that and trying to slim it down. And generally, the message we're putting out to them is they're very strongly encouraged to do ALDP. Although we haven't quite got to the point where we're saying this is a mandatory thing. I like to think that we will get there with time. So something to keep in mind. There's a discussion about how we build on accelerated leader development, because ALDP gives us a good foundation and gives us a common language across the organisation in terms of how we talk about leadership, etc. But there are additional very specific things that we think may be focused on some of our clinical leaders, and there's a bit of discussion about what does ALD plus look like and how do we link that with the wider thing that we're doing, including induction for new colleagues, etc. I moved from ALDP to e-rostering. So e-rostering has caused some issues in terms of discussions, and there have been a couple of pilots that have been tried in particular areas, and we've struggled. It is sometimes framed as resistance from colleagues, and I think in fairness there probably is a little bit of that there are things at the root of that resistance. What we're learning is that the software Allocate doesn't have the nuance to deal with some of the complexities of specifically medical managers. So where we've tried to implement in certain areas, it has sometimes been problematic. And so there's already been an agreement that a slightly slimmed down rollout, which specifically looks at more straightforward things like absence leave, etc., that kind of thing. As we further sort of understand how it would work in the medical space, there's also a shortcoming which has become clear, that Allocate can't do what we call self-rostering, which again is sort of evidence-based to increase satisfaction and retention and quality. So quite important, and we already had it in pockets in the organisation. So I think what I'm trying to say is we're committed to e-rostering. We're committed to doing it via Allocate. In the interim, as Allocate's functionality develops, there will be other solutions that are required as well, which we need to take into consideration. And Jack and I were having a discussion about something around that as well, related to self-rostering. Thank you.
Jude. Thanks. I don't want to repeat what people have said about to mandate, not to mandate, but I want to go to the value of the leadership programs that we put on and how good are they, because I think we all know what is really the hook, which is not the mandating, but actually people leave on their program saying, you know what, that was great and I learned something from it and it was of value to me. So there's something for me, and it's really difficult when you're designing a generic program that cuts across a range of leaders who perhaps have some different experiences, qualifications. You know, I'm sure there's lots of our leaders that have done masters in leadership, degrees in leadership, or they're on 9/11, or some of these other big national programs. And so, you know, things have got to be additive, I think. And I think, so two things for me: whatever we design going forward, I think we have to take the feedback from ADLP. Okay, what are we hearing? And it might be from those at 80 and above. What are we hearing feedback, and how do we build that into the design of something that hooks people to want to do it? But it also talks to, I think, the work on leader revalidation, because our leaders, if they get some revalidating, may be doing other things in the leadership development space that are contributing to their personal development. You know, but it's perhaps not through area people. They can demonstrate that they are continuously professionally developing.
Thank you.
Dr. Badair, my learned colleague. I would just say on the e-rostering point, whilst I accept, and we've obviously got to listen to our colleagues, it's important. We are not the first organisation to implement allocate e-rostering or e-rostering for pay. It is a newer phenomenon for medics than it is by the of the wider clinical community, you might say. But I think before we get into firm decisions on watering down, it would be good maybe to take some of those colleagues who've got the greatest angst to look at others and go see what is happening in other trusts, particularly if somebody in a particular speciality is saying, well, I have angst about this and it's not working. I'd be very surprised if by now that Allocate haven't got some examples that we could take, and I would suggest that people go see, not a Teams meeting or whatever else. So just before we maybe accede to the watered down version, could we maybe take the opportunity to make sure we have thoroughly got to see what is happening elsewhere? And if what is happening out there mirrors what our experience is, that's fine. If not, I would suggest that we kind of stretch ourselves a little bit. And for me, this is a classic example, which is akin to get it right first time good. There's learning out there, there's knowledge out there. It doesn't have to be that we have to recreate the wheel all the time.
So, if I'm patient. But very all our players were absolutely committed to the stretch. It is by Allocate's own admission that there are particular shortcomings in the system, which we're discussing today.
Thank you. Well, that focus on people and education, diving down into a much broader discussion on leadership and making things requirements mandatory and so on. I think there are just a few important points to come out of that. I want to start with the idea of leadership as not being a hierarchical form. And I think the importance of that is evident in the way in which there's been embracing quality improvement. And the point about quality improvement being successful is that it actually comes from the front line. So it is not, leadership is not necessarily hierarchical. The very fact that we have something called quality improvement means that implicitly we are putting into practice that leadership does not reside at the top. Goes throughout the organisation. The second point that I think was noted is the idea that you can't just say, right, we're going for this clinically led model. I think what's being indicated, being referred to, is it's actually we need the scaffolding there to know that we have that little based matter to give people that confidence and experience to actually lead, that they are confident to do that. And finally, I suppose it's a general point, not necessarily specific to medics, is the point about going and actually seeing what's going on in other places. That it may be a way in which the idea of the rostering can have a different view once people have been to see what actually. So whilst we may not have expected to have that kind of focus onto this topic, I think it's important to note some of the important points that have been made. Could we turn then to the Green Recommendation Oversight Programme Group? Rafiq.
Thank you, Chair. So this is our report from the Green Recommendations Oversight Group. Just as very brief context, to give us maybe some time back, we have historical issues related to the practice of a particular spine surgeon. So we have two reports that come from the board, one looking at safety aspects and impacts on patients, and one looking at organizational culture, the Breen report. The Breen report came out with 6 recommendations, which we have all seen, and the board tasked me with putting together the group that will oversee the implementation of those recommendations in the organization. First meeting of that group, I think I would say it was a very stimulating meeting, some very good discussions and good colleagues on the table who were in that meeting. I attached the AAA report. Broadly speaking, things I would just throw out are the work streams within the working group essentially align with the 6 recommendations. So if you look at the terms of reference, you will find there are 4 work streams, and in the people work stream, there are some sort of work streams that apply to the different work streams, different recommendations. The terms of reference we would like approved by board. Happy to take questions and comments. And the other thing that I would just like to highlight is in the discussions, specific focus around the 2 first recommendations, the apologies to affected patients and their families, and to affected colleagues, where we started off the conversation thinking that this would be a bit of just reviewing the fact that the apology had happened, appropriate communication had been sent, and we would close down those work streams. There was a very, very good, rich discussion around how we needed to make that engagement a bit more meaningful, and so there's a bit of additional work that will go around this. And I will pause there and happy to take any questions.
Julie, thank you. I don't want to touch anything because I'm not used to it. I just thought it was worth adding to what Rafiq was saying, because I have, since that discussion, had a couple of really good conversations with the colleague who's representing patients, who's actually is known probably to colleagues around this table, and has a lived experience of this, and has has been kind of living with this for a long time. She's really keen to work with us in kind of making sure that the communication around this is really clear and understood by everybody. And one of the commitments that we've made as a group is to bring a paper to board that can be understood by anyone that would choose to read it. And I think, you know, that kind of also sets us up quite nicely in the future for doing that with other issues. But it's really positive discussion, and quite in awe actually of sort of, you know, how she kind of wanting to support that process. So I'll continue with that. I think we're also going to set a couple of standard things that we're going to do around communications in that group, which will also be quite good for us to adopt really as an organisation. So asking ourselves what we would like to communicate, what those messages are, and to who. And I think that actually set a really good standard for what we could do in the future. So really positive meeting. In fact, probably one of the best meetings I've been in since I joined.
Thank you. Jude?
Yeah, just a question would be on approving terms of reference. The group meets 4 times a year, and then when I look at its duties, it says that it will review progress and intervene, it will ensure appropriate timely sensitive communications are done, it will review and escalate. It's just a question, is the frequency enough in order to deliver on the duties?
Yeah, thanks, Jude. We did have a discussion around that. So what we decided was that the regular meetings would be quarterly. We had a meeting in June. We will have another meeting in July, just because the meeting in June we sort of felt was a kick-off meeting. And so we'll have a meeting in July to look at all the work streams. Then we will resume quarterly, and the group will keep that under review in terms of whether we think we need to change the frequency. But it felt like that was about right.
Tim?
Yeah, Rafiq, it's just a quick question on the membership with the spinal consultant and the patient representative. are they there representing their colleagues and representing the patient body, or are they representative of IE and just there as individual?
So they are there bringing the voice of affected patients and the voice of affected colleagues to the discussion. Essentially, they're not necessarily representing particular colleagues. Obviously, the patient representative chairs the wider patient group, so bring that voice, and will be a linking to communication with them as well. The spinal surgeon colleague has the lived experience, and we needed a clinical colleague who would live through this to be bringing that voice as well.
Yeah, it's just worth kind of, I know you will be kind of attentive, that they are of the two members of that group. Everyone else is kind of there as organisational kind of leads, but those, it's just worth being kind of careful around whether they are representing or representative of.
I can answer that question.
Julie.
Right, thanks, Steve. So yeah, I agree. I think part of the reason why I've met separately with the person who's representing patients is to understand what that looks like. So we spent some time together last week creating a stakeholder map specifically for people who are affected, patients, and I'll do the same thing with a colleague as well in the spinal service, because we know that the group that call themselves the staff groups, they are not a single group, if you like, they're different entities to that. So I agree it's really important that we know kind of what's important, so we're not just communicating with that single person, but I'm confident that in having these conversations, we understand what we're saying to who, and that we're getting that kind of right, and that's why I'm keen to make sure that whatever we write and whatever we create makes sense to everyone, not just something that we might write that makes sense to us.
Thank you.
Can I just add that I think speaking to some of the people that Julie's referenced and others, I think there's a real desire for people to feel that this is this remains a live conversation and isn't something that in effect just gets put off into the sort of long grass. That actually that somebody could be 3 years from now and looking back and be able to see how the learning. So if you think about the 5 elements of the response, we'll be able to look back and see how that has influenced and changed the way we work in our organisation, and for it to be tangible. So that's not easy, but I think that's certainly a really driving thing around that. We're moving away from sort of the analysis of what happened to how do we make sure that the lessons learned become true lessons learned and become a part of the way that we operate. And I think I would just echo a little bit of what Julie's reflected in terms of the spirit in which people are coming to this at this particular junction.
If I may add, Chair, to that as well, just the presence of those people on the group gives us that additional validation from people who've lived all the experiences that the intervention that we are proposing and the shift of making the organisation is actually relevant to their previous experiences.
Can we make Jeff's point the last one, please?
Thank you. On Tim's point, the discussion meeting that was in attendance was that in the same way as Julie said that the patients and their families group is not a single cohesive entity, same is true of the bullied staff group. And that's why we were keen to ensure that there is appropriate support for both groups so that they can be helped to both corral their input to these meetings and be informed of the outcomes of these meetings on a continuous basis. It's clear from what Julie said that that's now happening for the families and the patients. I think they said she would go away and make sure that there were similar level of support and process events for the body staff group, and we need to make sure that happens. On Bowen's point about the performance of this group and how it's perceived, and not exactly what is said. We also said that some of the action has to be seen to be happening quickly. In other words, not we will do to ensure this can never happen again, and we know it will not happen again, but also what's happened already that helps us on that journey to communicate not things are going to happen, things have happened. I think that's really important as well, comms on this.
Thank you.
So, Chair, I think this will be the final comment because I know you're keen to move us on agenda-wise. I think just a couple of points. I think one is also just worth pointing out that NHS England will be offering us a bit of a rapid review around some of the stuff, so from a patient safety point of view, in terms of immediacy and now, there's an opportunity there which we fully embrace around that. So I think that we're welcome. And it's also worth just pointing out that I am personally systematically working my way through meeting with colleagues one-to-one. And I've met several of those and taking their reflections on the report, so on and so forth. So that element of interacting with members of the bully stepping group, that is something I am personally doing a piece of work around that. But for reasons that have been articulated, and these are not my words, but they're words from some colleagues who were in that original group. There are some colleagues who do not see themselves as part of an homogenous group. And I think it's very, very important that we respect that analysis, which is part of the reason why there hasn't been a pulling together of that group, and why for the third tranche of work is those individual conversations and an opportunity for people to feedback what things have meant for them. And it's not just the bullied stacking group. There are other people who work for us who were triggered by the report, who may not have featured but have made requests to me for conversations about the impact of the report. So that's an additional group of people who certainly I'm working through to make sure that their voices are heard around some of that. So I hope that gives some sort of assurance that that element is not just about the patient element, it is also about our colleagues who were particularly affected, and you know that is something that I am directly involved in. Yeah.
Thank you.
So with those clarifications and points of assurance that have been made with this focus on this item, can we note the clarifications and also agree in terms of welcome? Thank you. Shall we turn then to audit report? Chris.
Thank you. This is the report from the May meeting, which is generally speaking looking at draft accounts and draft quality accounts. I'll refer you to the alert in paragraph 1, if I may, which is a result of the audit advising us that they will be providing moderate assurance, which is a downgrade. They have said that this is a similar sort of position to many other organisations that find themselves in a recovery and financial position similar to our own. There was an issue though, however, relating to our response and action in relation to audit recommendations. And I think that we focus very much on patient safety and experience in our. There were some significant limited audit reports which have been looked at by various committees. And in terms of the speed of response and the number of occasions that dates have been required to back, that gave the auditors some cause for concern. So I think that's something for the future that we need to balance. I think they have to recognise that there is, without doubt, a capacity issue. And so it's even more important when dates are agreed on audit recommendations that they are appropriate given that some of them may have patient safety connections, but they're also realistic in terms of being truly able to meet those deadlines. And I think that that will help us as we progress during this financial year. Estates and facilities, you'll see featured again. I'm not having a bit of a downer on them today. It's just that it's cropped up in a number of meetings. This particular one related to the annual report. And firstly, I felt that an annual report was something of this nature probably not appropriate. But having said that, there were some non-compliance in some areas which were of significant importance, particularly around the area of fire and safety. And I've asked for that to come back again in August. And between now and then, I would recommend that executives keep a watching brief to ensure that they are satisfied with the progress being made, because those are important areas for us to keep under review. As Tim mentioned earlier, there is a question as to where estates and facilities sits appropriately within our government picture, and we have found during the last year that it has fallen between two stools in some areas. So I do think we need to have a better look at how we have better governance and assurance around this. It's for an estate such as ours, and the important area of work that they have, it's a very important thing for us to reconsider. Finally, I'll just refer people to the forward look of our audit plan for 24/5. We have tried to focus on what we thought were going to be extremely important to us, such as the BAF and risk management, but also our CIP, of course, and in relation to our recovery, looking at areas such as cancer and management of waiting times. We've also asked for equality diversity to be audited in relation to legal commitments, requirements. And as I've mentioned before, I feel it's important that we progress with an audit on translation and interpreters for particular. So I would advise people have a look at that, because I think that's an important area for us to be sure that we're satisfied that we're focusing on the priorities for the organisation in our audit programme for the forthcoming year. That then concluded my time as chair. I'm very sad to say that I've had the opportunity then to pass it back to its rightful owner, Crowley, and really that was the end of my tenure as chair of the audit committee.
Before we hand over to Tim, I think we need to just focus on the recommendation following your meeting, Chris. So we have here a recommendation from the audit committee that as a provider of commissioner requested services, the NCA has a reasonable expectation that required resources will be available to designated services within 12 months from the date of the statement, as required by condition COS 7, continuity of service of the provider licence. Can we accept that recommendation? Yes. Okay. And thank you, Rhoda, for your tenure in that chairing. Thank you, Chris. Over to you, Tim.
Thanks very much. Yeah, I'll just be quick, but we do need to kind of just cover off the accounts. But before that, I mean, just one limited assurance we did discuss at the June meeting was medical devices. Again, it kind of revealed the difficulties of kind of which portfolio that lay in and which committee would look at it. But we had Lorna, Chief Digital Officer, to kind of talk to the recommendations that sat within that. But turning to the accounts just for speed. So draft accounts came back to us after changes that have been made since the committee that Chris referred to in May. And we gave authorised delegation to the Chief Exec, CFO, approve and submit final version. Received the external draft audit completion report. The headlines are that the auditors anticipate issuing an unqualified opinion without modification on our financial statements. There is further work to do, particularly around the pension issue, but that's an important headline for the board. It's important as well that they're in respect of value for money, the external auditors had one significant weakness in respect to the arrangements to report in relation to the arrangements that the trust has in place to secure economy, efficiency and effectiveness. This kind of is predicated on the fact that we have a deficit plan and our reliance on a high level of savings, which are kind of inherent in our financial position. Also, to reference, external audit satisfied there is not a significant weakness in our arrangements in relation to governance, and they're also satisfied there is not a significant weakness in our arrangements in relation to improving economy, efficiency and effectiveness. So those are important points to raise. I won't go into the other items are clear within there, but the main one was to communicate the issues around the audit opinion. Also worth noting, and was what came out of the process for this year in particular was the strength of the relationship, and particularly the performance of our finance team in the quality of working papers were particularly commended upon by external audit. And I think that talks to the kind of leadership in finance and the strength of the finance team around the production of our accounts. So I just want that to be noted by the board.
Thank you. Thank you.
But can I just say in support of that? I mean, I've been around audit committees since I've been appointed as a NED, and that is the strongest endorsement I've ever heard of good joint working relationships and the outstanding work that's been done.
Thank you for that comment, because I think it emphasises the point that Corinne made earlier about how we should acknowledge the work done by everybody in relation to improving our financial position. So, thank you. Can we note that update and that great.
Yeah, just thank you. It's a team effort as always. The team that I work with, fantastic. One of them's here today observing the board. So, it's a team effort, but thank you for noting that at board. I'd just like to comment on some of the observations made on the status of facilities, because I think it's really important to come back to that. There is one perspective from this that I feel where we have started to improve in this area, and I think the reason that we know we have the issues that we do today is because we're getting further clarity on them, which by default means something is improving, because we are raising risks through the Capital Group and Finance Committee around things like RAC now, and we received a paper at Audit Committee from our Director of Estates and Facilities, just articulating the next step on how to improve the governance. There was some good feedback from Audit Committee about that. When we looked at the oversight of fire safety, absolutely there is work to be done, but I felt like it was more credible to understand where those areas were that work needed to be done, and where we had some sort of assurance that work had been done. Equally with medical devices, we know that we commissioned an internal audit report to help us support with some of these areas of concern. So I do absolutely take the criticism, and it's a constructive one, that we need to integrate it more smoothly. But I do feel like we've made steps, even since that audit committee, to do that, and I feel like we're able to comment on the things that we are today in some of the areas because of that improved oversight, but we do need to do a lot more.
Thank you. Lorna, and then Jeff, the last contribution, please.
Thank you. I just wanted to elaborate a bit more on medical devices. I think it's worth educating the board a little bit. Medical devices themselves are owned and managed within our estates and facilities team. There's a dedicated specialist team that look after them, including managing the assets. And historically, we've always audited the controls around medical devices and the processing around managing them, and then done a separate control around the IT cyber security related to medical devices. And we end up with 2 different audit reports. So on the back of the audit committee conversation, I've already picked up with my colleague in the state of facilities about how we align and look at maybe how we do one audit report. And the other broader impact here is that as we evolve from a technology point of view, actually our use of medical devices is growing. Our footprint in terms of extending into the home, extending further services to patients, actually will probably drive more demand on medical devices being part of intrinsic how we provide services. So we, again, we've spoken already with my colleague from the state of facilities about how we might make recommendations to strengthen and change about how we think about that as a core service. It will become far more integral than we perhaps see it today.
Thank you. And finally, Jeff.
Actually, I think it's important to note the finding by external auditors that they see significant differences in our value for money arrangements for the 2nd year running. And at the audit committee, we did ask for some information on just how many trusts in Greater Manchester and then in England are in a similar position. So we just understand, how widespread is this, how much of that there are. It's a bad situation. It doesn't make it easier for others in the same situation. I think that context will be important for us to know.
Thank you. Could we just have a 5-minute break before we move onto the change portfolio board? Thank you. Could we turn then, colleagues, to the report from the change portfolio board? Aaron.
Thank you, Chair. I'm going to do a very good reflection, and again, working on the assumption that the data's being read, so I'm just going to pick out some of the highlights. The 2 sets of reports that we've got related to the 20th of May and then also the 17th of June. And then what can I follow up is the independent insurance piece from that. So just a couple of things to highlight. So certainly in terms of the 20th of May, the reinforced autoclave aerated concrete rack replacement programme was quite an important consideration in terms of discussion. I think one of the themes that's pretty important for the change portfolio board is to really understand the risk mitigation, because we're going to be living with some of this for a number of years into the future. We know that we're not allowed, but certainly we've got our own fiduciary duty towards making sure that our patients and our colleagues are as safe as possible. So risk mitigation and focusing on that will be an important aspect of this piece of work. I think from the other area I'd just point to in relation to the 20th of May, and obviously there's a timeline scenario around some of the, is the referencing here to the target operating model, and particularly a risk in relation to engagement. We are in a process now where we have moved on from probably where we were at that moment in time, and I'm sure you need to Estelle can talk about where we are at, but there is a link in to the assurance points that we'll talk about a little bit later around the staff engagement piece being around that, but also the representation of staff through this process. And I think it's absolutely understandable, certainly the staff side representatives, when we're talking about a change of this scale and other changes to come. But bear in mind now, we've had a mutual agreed resignation scheme, we've had the target operating model scheme, we've got impact one way or the other around the clinical leadership model and so on and so forth. So quite rightly, you'd expect staff side to be wanting to be focused on making sure that their members' interests are supported to the full. So we're working through some of that, and some of that has now moved on, albeit in terms of the target operating model. We do need to make sure that some aspects which we've not progressed in terms of, we're not in a position where trade union colleagues are satisfied with where we're at. that we do the work to make sure we meet the threshold that enables us to move on. But by and large, that programme is now moving on. I think what I would also say is that when you then relate that to how you want to achieve cost improvement planning, this is the real reality of what happens. That you can have the very best plans, but then there are other factors that come into play, and the target operating model is a good lesson and a learning point for us on this, and we need to always make sure that we have our side colleagues working with us at all times. If I just move on to the 17th record, and again, I'll show how to take any questions on plenty of in terms of the 17th of June piece. I think the point I would pull out from this particular piece relates to the advice, particularly in relation to the programme initiation document that paid in relation to urgent and emergency care in that particular programme. This was a programme where there's been a lot of good work done in this, and some of it reflects some of the earlier part of the conversation that Jude talked about, some of the things we're working on. But we probably felt in the discussion that we had that there was just probably a little bit more work to do before we could sort of fully endorse the project initiating document around that. And some of that was linked to, for example, there was quite a long list of benefits. And what we probably would want to see is, okay, so this is the world of what we want to do, but if it was our last pound, you know, what are the 4 or 5 must-dos that would really sit within that, and how would we know that we've landed on them? So what would be the description of that benefit realisation? So that's just a piece of work that we've asked. And then another thing that was linked to that piece of work was that we probably felt that just a cross tab to things that sit within the CQC report, for example, we've still got an outstanding situation with Salford in terms of the safe domain, and that still remains inadequate based on the 2022 CQC report. So, you know, to have an urgent and emergency care excellence programme that doesn't have the cross link to that didn't seem quite right. So we just asked for, so by and large, it was sort of like 85% there as a piece of work, but we just felt that we just needed to have build additional pieces to help us work through. A couple of other points just in terms of that. There's a particular piece around it's the old sort of strategy on page type stuff. So there's a piece of work to kind of, I think, get to a situation where we almost like, I mean, we can't cheat, so we can't use an A3 page, we've got to do it to an A4 page, but to be able to describe, you know, saving lives, improving lives, to talk about 6 ambitions, to talk about strategic objectives, to talk about the change portfolio board, and to have that in a way that you could just see that and be able to say, okay, yeah, I understand now the future I'm stepping into, so that, you know, all of us will be able to see quite quickly what this looks like. So there's a piece of work that we want to talk about there, and some of that links into communications, but I think there is something about being able to consolidate this and be able to see it, talk about it in a simple fashion. It's doable, but you know, that's one of the things that we talked about. There is reference in this note as well about what are called the efficiency opportunities. Some of that is linked to some of our risk appetite, or we might talk about high risk opportunities, and so on and so forth. So we're on with that piece of work and trying to work with that. Those are just some of the things that I wanted to pull out, if I could do, Chair. And if it's okay, I'll pass on to Louise. And again, just to re-emphasise the point that, you know, this is the part of the conversation where, you know, we can do that independent assessment of where she thinks we are at this moment in time, and Joe may contribute to. Please.
Thank you.
Chair, I think this is moving into the next agenda item. We haven't meeting yet. So just really just to draw out 3 things in relation to the portfolio assurance report itself. So that's the slide deck in the pack. But if I can draw your attention firstly to slide 4 of 32 in the slide pack, and that's where we've got the 2 graphs showing the trend of the overall governance and delivery ratings, the assurance ratings. And we can see there that there's been an increase in the number of programmes in the portfolio to 15 this time. And that's after Change Portfolio Board approved the inclusion of the RAC reinforced autoclave aerated concrete replacement programme that Owen referred to. And 11 of those 15 are currently being assured and are assured through this version of the report. And we can also see there that there's been an increase in the number of green RAG ratings. So in particular around governance, there's 1 green RAG rating there, which is procurement. And from a delivery perspective, there are 3, which is procurement, the maternity improvement phase 3 programme, and estates facilities. We can also see there that there are 2 red RAG ratings for delivery, and that's in relation to the corporate target operating model programme and medical workforce. And those 2 areas are both in relation to the effectiveness of stakeholder engagement. Secondly, if I can just draw your attention to the maternity improvement phase 3 programme. So we can see on the following slide, on slide 5, that the majority of the sub-criteria for the maternity improvement programme are RAG rated green. It's a really well-structured programme, adhering to programme management principles, with delivery on track and risks and issues, albeit some really high scoring risks and issues in there being managed appropriately. And the only amber RAG rating that we can see along that row relates to approval of the quality impact assessment, and that was obviously at that point in time, and establishing a review timeline for the impact assessments as well. And then finally, if I can just draw your attention to the clinical leadership model programme on slide 5 also. So we can see there that the clinical leadership model programme is RAG rated amber overall. And I just wanted to add that whilst significant progress had been made in respect of programme governance at the time of this particular assurance statement, particularly around stakeholder identification and mapping of stakeholders, this appears to have stalled somewhat, and we're not seeing sufficient progress around defining the programme and its benefits, and that is likely to result in some more red RAG rated sub-criteria in the July assurance statement, which we're carrying out in the next week or so. And if I can also just invite Joe just to say a few words about how he's seen a portfolio assurance report of this nature used to best effect by other trust boards.
Thanks, Louise. Thank you, Chair. This follows actually a very helpful meeting Louise and I had yesterday with Tim, and Rachel is not here today, on a couple of questions that came up, if you remember last time, which are around the picture of where the portfolio takes the organisation. And Owen's referred to the work that's ongoing to produce that picture, and we shared some early drafts of that with Tim and Rachel yesterday. And then the second point was around the use of the assurance material in the forums as I've seen it used before. That's not to say that's you must do with it, of course, but it just offers you a perspective. And I think this is probably true at the Change Portfolio Board and at this forum, is that simply put, it's your portfolio. This is your strategic direction for the organisation that you share in common, and that's a line I've used at the Change Portfolio Board. So while there are very discrete and appropriate responsibilities placed on an SRO, they shouldn't feel either at the Change Portfolio Board or in this forum that they're on their own with the programme. They should be feeling that they're taking a lead, they're the captain of that team for that part of the mission, and that they're fully supported by everyone around the table. What comes with that, of course, again, is that responsibility is also the challenge as well as the support. And what the ratings do is they guide you into the areas where you might want to ask questions around whether further support is required to improve the picture that you're seeing in terms of the confidence levels, or indeed the challenge of, well, we can see there's an issue, what are the plans around fixing that and by when will that happen? So that's the kind of use you would put it to. What you would hope to see as a system like this matures is that the conversation, both here and at the Change Portfolio Board, if I can put it this way, wouldn't be involving myself or Louise, because the questions wouldn't be coming to us. The conversations would be between colleagues who are SROs and their non-executive and executive colleagues around the table. So that's where it might go to in the future, because up until now, I think we've received, happily received, I might add, lots of questions about how does it work, what's the process, what's the design. But I think now we need to move into that next phase where this is now going to be the regular picture. And if I were looking at, I think it's page 5, isn't it, on the report dashboard, the high level, one's eye is drawn to the reds for the reason they're signposting something. And when a programme is amber, that's also saying something. So just as a few months ago we were saying, well, let's embrace the red, I think was Owen's term, and let's not get in too comfortable a clinch with it. But I think the same is true of amber now, because an amber rating across the piece for a programme, as Louise has referred to there, that's not a good picture for one of your major pieces of strategic change for the organisation. And so that should be leading you to have the conversation about it. The one final point, and it gave me pause for reflection overnight, that we discussed yesterday was, well, how much of this should be addressed at the Change Portfolio Board and how much would one expect to come through to a trust board? And so I sort of tested myself overnight, both consciously and unconsciously, I think, and woke up with part of an answer. And I think it goes back to the issue that this is fundamentally about change. Lots of the other issues that come up through other subcommittees, bearing in mind Change Portfolio Board is not a formal subcommittee, but it's run very professionally like one, which was the intention. That's around core business. And while there are challenges in core business, it's very regular. You all been party to your audit committee for years and the material that goes through it, same with finance committee. So change boards are, difficult beasts to manage because change is a difficult thing in large and complex organisations. So I think you can expect that issues will come through the change board and they won't have been resolved, and they will appear here, and they're quite thorny issues, and that they may require your attention, and that certainly then the SROs will benefit from your engagement and your support in assisting them to tackle whatever the blocks are on the programme or the issues are on the programme to take it forward. I think that probably does it in terms of just contextualising what you're seeing and just offering some signposting on how you might want to use it in the future. Thanks, Jen.
Thank you. Given that, Myriad and then Jen.
Thank you, Chair. Thank you, Louise and Joe. I know we've talked about this being a new learning, and we're evolving and we're working out together how we use this in the future. And I appreciate that you've taken the feedback. But I think I look at the report and I think about assurance. It's giving me assurance that the programs are running to plan. But I'm not too sure whether I get the assurance that they're delivering for the strategic objectives. And I know, Ian, you've talked about, we're going to look at Owen, you've talked about the objectives and making sure that we are clear on the benefits. But I think we need to get to that place now, if there was focus area around what are the KPIs, what are the metrics that we are actually delivering. Because I look, for example, at the maternity improvement one, it's all green. But then I go back to the conversation we had earlier around maternity, and we had quite a number of KPIs that were probably not going in the right direction. And that then tells me this is probably not giving me the assurance that what we're driving here is going to get us there. And I'm not saying they're correlated, but I think we need to make sure that we're answering that question. I think there was also about 50% of our CIPs not yet identified. And I think if we're going to start bang for money, I would expect that this is focusing on how do we get that 50%, how do we make sure we have the initiatives and we're tracking it. I don't expect that we will track every single one of them, on here, but at least the assurance that the 50%, which is a big chunk of our CIP, is being monitored through this. So I think there's a bit around kind of making sure that benefits are clear, how we support the key initiatives like CIP and how we deliver that, and making sure that this gives us assurance that the strategic initiatives are being delivered in addition to assurance that the programs are on track. we could capture that at least for the next one, that would be great. Great progress.
Thank you. Tim.
Thanks, Chair. Yeah, I mean, thanks to Joe and Louise. It was good for Rachel and I to meet with you yesterday. Kind of it's helped me kind of understand the document and use it more. And kind of now I understand it a bit more. I'm kind of I'm looking at the AAA reports, and they kind of say nothing to see here. You know, I kind of would like on those a bit more evidence of the challenge that is going in on the individual programs, because you read them and we're not flagging, for example, target operating model, we're not flagging medical workforce, and we kind of need to see that there. I think. I suppose that then leads me, it picks up Miret's point around delivery. When we look at the two that are flagging red, and I look at the assurances that Louise has set out, if I look at medical workforce for example, that they aren't assurances that that's going to get back on track. So I think we need a bit more discipline in kind of signing off these actions will get us back on track. And then when I read kind of some of the gaps, the deficits, we don't have a program vision, for example. These are pretty big fault lines in those programs. So I guess I suppose in the spirit of what Joe's kind of set out of how we kind of have a meaningful discussion on it, it probably would be around medical workforce, kind of hearing from the SRO your confidence in that assurance actions getting us back on track with that program. And in future, me being more assured, because I can see that in the AAA report. Yes, but it is that question really today, I guess, is around your confidence in us getting back on track.
Totally. Like to respond now? Yeah, okay. Great, thank you. So thank you, Tim. Absolutely note that from a medical workforce perspective, the program, I think, is at a bit of a turning point. So there were issues with bringing together some of the key projects that sat under the program, which over the past few weeks we feel are sort of properly coming together. And so my expectation is that from an assurance perspective, that there will be further clarity on what the actions are. Are they going to show us that that translation into better assurance and clarity on where the money is coming from a CIP perspective? So our expectation is that yes, I feel that in the pipeline now are the actions that will get us there. And the point about the vision, there is a program vision. It is being retweaked. It just hadn't quite filtered into our sort of documentation in a proper way.
No, yeah, I understand that. I just think it would be good to get that discipline of when, by whom, and when the dial will turn. There's quite a lot of narrative in there at the moment, but yes, that will be helpful. Thank you. Okay.
Yeah.
That's fair. I think the medical workforce part of this is a really good example of a general point for me. The quality of this course here on the medical workforce is quite different from the report that goes to finance committee on the overall workforce. This gives me real specifics of before pandemic and after pandemic. That really Tim's not giving me a short check that make the difference, but at least the problem was clear. I think that's as a general point. I go to finance committee, and to me, it's not business as usual. We cannot do finance committee business as usual, otherwise we're going to run out pretty, very fast, aren't we? It's got to be about change. So we've now got this excellent evidence over here, the separate point that our organisations are operating over here, supposedly, doing something far more than it can't be like that. Don't like finance, isn't it? So I think there is an issue about how the two start to come together in some way. But I like the quality of this. Except that it doesn't give me clarity on the cost improvement programme. So how is all this adding up to turn the corner on the cost improvement programme? We know we're not where we need to be. I would have hoped that this would include for every programme what is the national target for this to achieve savings, and not all the about savings, but where they are, how much will it save by when, and secondly, where there are workforce implications, and there will normally be workforce implications, how many staff or what type will be affected, how by when. That clarity, I think, would just bring this to fruition for me and give me much more assurance that we're going to get to where we need to be.
Thank you. Jude. Thanks. Maybe so might tie some things together. I think, you know, having worked with Joe for over 12 years on and off now, we'll get to a sense of maturity around how we use this when the SROs are using it in their own programmes, and we're not there yet. So, you know, I can only speak for myself, but I don't think I'm any different. And some of it's a timing issue about when the assessment of the independent assurance is completed and where the programme boards lie. But I would anticipate that I start to take this into my programme rather than it just being marked at a portfolio board, because actually as an SRO it's telling me some things, it's telling the programme team some things, and that's really where the conversation needs to be happening. I would suggest not a, you know, the challenge might need to come at portfolio board, but really the conversation about what's happening in this programme, what needs to happen at programme level. So I think there's a next step in our maturity around this about where SROs are using these assessments within their programmes to drive that conversation, and what needs to happen next. I want to go back to the issue about benefits, because one of the things that these assurance reports are talking about is actually, are benefits defined, you know, are there benefits trackers, are they being realised? That is a job for the programme to be looking at some of that and challenging it. Some of the benefits are reflected in our SIP progress, but not all of them. So back to urgent care, are the 12-hour numbers coming down? You know, what competence have we got that coronary care is being eliminated, etc. So, you know, we are, again, I'm speaking for my programme, but I don't think I'm in any different position than others. Developing those benefits dashboards that are really visible, you know, requires a bit of digital, you know, BI input from Lorna's colleagues. So, you know, there's a bit of building that is happening as we go along, but it may be that we get to a point where those benefits dashboards can be seen more visibly, potentially at the Portfolio Assurance Board, because they are supporting those programmes. But I can say, in our programme this week, you know, one of the challenges that we've had on the money is that the benefits dashboard, so some of the measures look like they're going in the right direction, and yet the CIP hasn't been transacted. So you know, there's a bit of a challenge conversation again that needs to happen at programme boards around what's benefits dashboards telling us and what's been transacted within care organisations or where budgets lies. So, you know, if that gives anybody any confidence about actually how the programme matures, and how we start to use some of this in anger, not necessarily at the board, not always at portfolio board, but actually how we're using it within our programmes to drive those conversations. The other thing that I just want to highlight, and I suspect again it's a bigger challenge across all programmes, is resource. So, you know, one of the risks that sits in clinical service excellence is people resource. What sits project management that you know, over the next few months will become vacant, and certainly, you know, I think I said earlier, sat with Lorna last night, we have a digital list that is this long, that is sitting across that, and I'm not sure, and neither is Lorna yet, whether that's even deliverable from her team. And if it's not, then we need to start to say, okay, what can or can't we do within the programme? And so I think that triangulation of interdependencies, so it's a question, I think, moves back to the assurance team about we've done that for clinical service excellence. It will sit in a number of areas, and I think we need to pull that together because when we're looking at resource, it just doesn't sit in the PMO team. It sits in other people's team and particular digital solutions that we're relying on to drive some change forward. So I think a bit of work that needs to be done to bring that to life for us as an overarching programme. Yes.
Jim.
Thanks, Chair. Yeah, I was doing my very level best to avoid answering the question at this stage, but I'm being drawn in. So just to respond to a couple of the specific points on the CIP benefits that arise out of this programme, I can say they are tracked within an inch of their lives on an almost daily basis. So there's a Monday meeting that Owen chairs with all the SROs where we see a report on every one of these programmes and the financial contribution it's making. I meet with every SRO, apologies again, every week for half an hour with your Director of Cost Improvement, and we go through the numbers in some detail. So I can appreciate what the problem is that you're enunciating here. It's how do we cross-reference that and make that easy for you to see, because the material's there. What we don't want to do is build a gargantuan beast that takes another separate office to try and generate, but I think we can just make that cross-referral work for us all. On the maternity one, it's a really good example actually. I was thinking ahead myself and seeing that dichotomy between the report we were seeing and this. This is because this is a specific programme to a specific scope. It's not an assessment of your maternity services. It's an assessment of, Jackie, or correct me if I'm wrong, phase 3 of the niche reports. End of. That's what this programme will address. And it's really important, I'm sure you'll appreciate, in the world of programmes that we stick with the scope. What we're assuring here is the scope of that programme, which is one important slice of how maternity is improving, but that's what it's addressing. On the AAA reports, Tim's point is really well made. I think both Louise and I have heard that loud and clear, and I think there is work we can do to cross-refer what we're seeing in the ratings in assurance terms to how that AAA comes through. I think part of that, personally speaking, is my own newness to your AAA format, and I'm only just really seeing now what you're seeing and how those two things are not marrying up in the way that they could. So I'm sure that's something we can fix. I hope those contributions help. Thanks, Chair.
Thank you. Yet again, I have the dilemma about the importance of the topic and continual colours coming before me. I'm going to be quite firm. Myriad, Rafiq, and finally Owen.
Mine is hopefully a quick one to come back onto, which is around kind of the benefits. And I think we're talking about the outputs of the change portfolio board, i.e. we now have a program, we have to track its outputs. When coming points for the improvement is now around the inputs. So what I would be looking for is that this program or this forum allows us to identify the things that would give us maximum benefit. So when I think about CIP, less about, of course, we have to track what is already applied, but we now have this gap at 50%. How does this help us to identify that so we can invest in the things that will drive that? There's a lot of capital programs here, and I think in the when we get to a mature state, these should help us to say, actually, are those the programs we should be investing the money in versus what we've got. A lot of this has preceded the change portfolio board, but going forward, anything that comes on here should almost go through that scrutiny that says, are those the 5 things we want to do because they will give us what we need to do. So it's a bit different to we track CIP activities. Yeah, we need to. But actually, are we then using this to help us identify how we close gaps or to invest in the things that will drive the biggest bang for money? So I think there's a bit of both of those things. Definitely the first one needs to happen, but the second one is about how we use it to help us close gaps.
Thank you. Rafiq.
Thank you, Chair. So I just wanted to essentially to comment on the top challenges around clinical leadership model specifically. It's a big program. It's something that we are all involved in as execs. And one of the things we've recognised is just the need for us to be carving out a little bit more exec-specific time to ensure that the brief for the programme, so to speak, is sufficiently clear to all of us and there's appropriate alignment. And again, I think that will sort of translate through into some of the things that we see on insurance.
Thank you. Owen.
Just on that final point first, it is exec specific time, but it's about understanding that we're not all captains in that conversation. In that conversation, Rafik is the captain of that conversation, and the interaction with me and other executive colleagues is to meet the asks and requirements that are required. That's a subtle change in the way that, you know, maybe has been custom and practice, because there's kind of maybe a kind of home impacts kind of thing. The problem with that is that sometimes it lacks the clear leadership about who is driving this. And sometimes, because there's a first among equals thing going on here sometimes, particularly when in positional power, chief exec, not in that conversation, but sometimes we just got to accept as executives that actually, I might not agree with Rafik today, but actually he's got the FRO responsibility, and therefore if what he needs of me is X, Y, and Z, I've got to agree to deliver X, Y, and Z. So I think the way of working piece that we're still working through, and that's why we have development sessions to help us kind of work through some of those changes. But just 2 or 3 points. Tim, I want to really make sure, and you know, we can maybe have a conversation offline if I am misinterpreting this, because there's a part in what I hear in what you expect from the change portfolio board and the challenge that takes place, and you know, there's been an indication that there is that challenge there. I'm sure colleagues who are in FRO don't think that when they turn up for the change portfolio meeting or a cost improvement meeting, that's just going to be a fluffy conversation and nothing to worry about. That's not how things work. But I think there's a bit of both. What do I mean by a bit of both? There is obviously the challenge that will take place in the change portfolio board context. Yeah. And whether through AAA or wherever else, there should be some elements feeling of that, so I definitely get that. But it's also a responsibility of the board, I think, to, if it sees things that don't chime or whatever else, there shouldn't be a reliance on just what the change portfolio board says. And that's one of the things, and it's a difficult thing to navigate this. It's one of the reasons why there's that open invite to a couple of non-executive directors as part to attend the change portfolio meetings, because that's also, I know Chris has attended that, Sue Lonham has attended that. There's also an opportunity then for them to contribute, but also to know and to be kind of sort of guardians for the board to know what is the requisite challenge taking place in those forums. So I guess to that point about change portfolio board and expecting to see that reflected, get that, but we shouldn't exclusively see that as the responsibility of the change portfolio board. We've got a board responsibility, and this is one form that we're saying we're escalating to the board for a conversation. I think, Jeff, there is a nuance to the cost improvement point, because sure, there are facets of maternity improvement, for example, that have cost improvement opportunities or income generation opportunities, for example, around CNST compliance and so on and so forth. But not every programme will have a direct cost improvement benefit that can be articulated in that way. So if I think about what you might see in the EPR programme, for example, you're probably going to actually see an investment bit for a period of time before you might start to see benefit realisation that you can describe as cost improvement. So I think it's not that every single programme that you will see in the change portfolio board will have a direct correlation to cost improvement planning. But I think it's legitimate that where that is the case, we need to be able to articulate that. And if there is any other benefits that are being derived that are likely to be, for example, in maternity, likely to be quality benefits, certainly life benefits, or if it is EPR, it's going to be about, data, information, and ability to provide better care. I think there is something about being able to articulate, but I guess I'm just making the point, not all of these programmes are about cost improvement planning, and we just need to make sure that we understand that nuance. I'm a little bit, I think we need a further conversation actually about the point you make about what should we be seeing within the finance committee, because it's an interesting perspective. But if you said to me, you know, what my sleepless night, well, my sleepless night is run rate. My sleepless night is knowing that, you know, we spent, I think 94, we had an average of £94 million on the payroll, and we've had a month or two where it's been around the £92 million mark. If those conversations, because that's the kind of day-to-day reality, if those conversations are not having an area of focus in a finance committee, or if I look at the cash position, because whilst it was good hearing Craig talk earlier about, you know, well, we're not at 5 days, we're at 10 days, we're not 10 days, we're at 19 days, I'm still doesn't make me feel particularly comfortable about what that cash reality is. So we're going to have a conversation, because otherwise I see those finance committees are going to be very, very long meetings about where do we prioritise our attention, and maybe that's the conversation. Well, I think it is a conversation we need to have outside of here and come to some sort of conclusion around some of that. Two other final two points just to make. There's also a thing about understanding. So if you listen to what Jude's talked about, she's talking about a capacity issue that sits within the programmes that she's dealing with. Part of the reason there's a capacity issue is a result of another programme, for example, like the target operating model. So what we've got to be intelligent at and understand that not all these programmes are complementary to one another, and that as a result of implementing one, you will create problems that you might not necessarily foresee at a point in time, but become apparent over a period of time. And again, I mean, I think this is high-end sophisticated stuff, but it is really about trying to understand that, you know, the interdependencies that may sit here are not always going to be complementary interdependencies. They could be things that actually impact negatively on programmes, and it's about how we have that conversation. So I suppose what I'm articulating there, certainly in terms of the change portfolio board analysis, is there's a level of maturity that we need to work through to get to that level of sophistication, but we're alert to it. And we've got an understanding that these are the things that we've got to have in view. And then I suppose the final point there is just about how some of these conversations take place. So, and this is something we're working at, and I would go right from a cost improvement programme meeting on a weekly basis, or a change portfolio meeting that happens on a monthly basis, or a board meeting that happens, you know, in the frequency that it has. Where we need to get to, certainly in the other two meetings that sit outside of the board, but I don't see why it wouldn't be the case with the board too, is if Rafiq, as an exec colleague, has a point to make or a question to ask of Jude, another exec colleague, we should welcome that questioning. You know, it shouldn't be that it has to be, for example, a non-executive director that can only ask questions of an executive director. And equally, when we're in a cost improvement planning meeting, you know, if a care organisation colleague wants to be able to ask a question of the chief exec or of someone else, that's the fluidity of conversation that we could be having, because we want to utilise and maximise the brain power that we've got in these various conversations. We're not there yet around that. And again, I think that that's a level of maturity. And part of the reason why we're not there yet is because customer practice has been more hierarchically driven. So we are entering a new phase, but it's an appropriate phase, because guess what? We're doing stuff that we haven't done before, but that's okay. So, Chair, I hope that gives some food for thought. And you know, there might be some points that people thought, well, I want to come back to on that. Please, outside of this forum, let's have that conversation. If there are some points where you think, like, yeah, I'm not sure I agree with him on that, or how do we get behind some of that point? Or that's it. Yeah.
Thank you. As they say, follow that. Really important stuff, thank you. Can we internalise and reflect and think about how we're going to make realities of some of the conversations that we've had, which is a long-term conversation. Yeah, but thank you. Could we continue then with charitable funds? Yeah.
Thank you. The report is set. So if anybody have to answer any questions.
If there are none, can we go straight? Sorry.
Question. The report says no funding requests were received. At an earlier RNI committee, that was the last RNI committee, we looked at whether there was a possibility for funding for the Centre for Clinical and Care Research to come to the charitable funds. Has that been, or is that still to come?
It's still to come. We did discuss it though. Jack Sharp raised the issue. We agreed that while we wouldn't want to fund the same, exactly the same work on a second one-off basis, if the research side wants to come back with a different proposal, the second one-off round, we would consider it. So we are expecting a submission that
Thank you.
Can we then go straight to the recommendations and in particular approve changes to the committee's terms of reference? And again, taking nodding of heads as slums. Thank you. Can we turn then to the integrated performance scorecard and just perhaps home in on anything which hasn't been covered, which is sorry, could I just say, do you think this is a really important improvement?
Yes, and thank you to Alex and colleagues for the work that they've done on it. Just want to pick up before we get into it. I think questions that Miriam raised right at the start, which is this is a monthly report, so it largely tracks metrics in our annual that talk to our annual plan objectives that shift in month. It doesn't talk to the entirety of the annual plan, the delivery of the annual plan objectives. So we've got more work to do that just doing in the background that looks at what were the delivery measures from the annual plan objectives, where are they all tracked, on what frequency, and it might be that there's something we can put at the back of this report that just shows the totality of that, what committees see it that way, because as I said, some don't move in a month and they might just be quarterly metrics going in the right direction, etc. But I think we do need to somehow collectively be able to see the totality of the deliverables and measures that are in the annual plan objectives. So it's a bit of work for us still to do. I'm just, I'll open it up to Ned's in a minute for colleagues, questions for exec colleagues on their areas of responsibility, but while I am in the seat, I'll just take an opportunity to sort of sum up the operational performance objectives. So I think picking up Owen's point before, when we were at Quality and Performance Committee, we had a risk of 14 78-week breaches at the end of June. That's where we were at that point in time. We were finished the month of June on 8, which is not quite our zero ambition, but just for context, we had 34 in April. We had 25 in May and 8 in June. So that's a step change improvement in the month. And again, a bit of context here. We had 3,467 in the month breaches as we stepped into January last year. So we are making significant progress. That said, if I look ahead for the next few months, we'll have, you know, while we've got to get to zero, we also have to maintain zero. And, you know, we've got 70 patients who were up over into 78 weeks in July. We've got 201 in August, and we've got 651 in September. So, you know, this is not static. Then, you know, we've got to keep driving that improvement. So on elective recovery, the area of concern 65 weeks for me continues to be dermatology. We continue to adjust with insourcing and outsourcing, depending what our workforce challenges are, looking ahead. But dermatology remains a risk. It remains a risk to cancer performance recovery. You can see that from the report. And we continue to work with our teams, GERV teams, enacting all of that improvement, putting insourcing, outsourcing solutions. We're really trying to come up with creative solutions. We've got GPSIs that we've now recruited starting to work with us, and we started a programme of work engaging with those localities where the referrals, so think about capacity and demand, where the demand is looking to be higher, so that would be Rochdale, where work is already ongoing. Stockport, we had a conversation with commissioning colleagues over in Stockport and GPs last week, and Borough, we've got a call scheduled at the end of this week, I think it is. So we are reaching out into those localities. And then the other thing that is coming down the pipeline is the GM care. And I'm still trying to work with our senior colleagues about locking down those timescales. They are not going to be enough to rescue us from the summer demand of 2-week wait, which continues to rise. Every time I come to the board, I say demand is at an all-time high. It is at an all-time high, so higher than the peak of last summer, which was higher than the peak of the summer before. So, you know, it is, those teams are fighting against what feels like a tidal wave, but doing a pretty good job. So it is a risk on cancer, and it remains a risk on 65-week recovery, but continue to work with the system, with our localities, and with the teams internally around that continued improvement work. So doing a great job, I would say, just at where we are, standing still. I think the other things that I will just want to pull out, I think we've talked about urgent care. We have received communication nationally about what some of those key priorities are. We'll discuss that in the next quarter and what assurance we have against some of those priorities, and we'll take it into also the locality partnership conversation that we'll have. And I'll pause there, and then maybe questions for whether exec colleagues or myself on the areas of performance.
Colleagues? Esther?
Yeah, sorry, I'm not quite sure how to use these. So I was just going to pick up a point on the sickness absence that relates back to the conversation that we were having earlier around tracking. So you can see from the report that sickness absence has increased, and whilst we have looked at some specific points within people on education committee, so specifically around welcome back to work conversations, formerly known as return to work conversations, and also around clinical support, sickness absence. I think there is something that Aziz, Nikki and I can do to look at how we're reporting sickness absence trends within the care organisations at a more granular level, to try to understand what is underpinning that persistent increase over the last 6 months, because we're very slowly getting towards where we were in April 2023, which was one of our highest points of sickness absence when we exclude COVID out of sickness absence.
Thank you. Carmen?
Thank you, Estelle. I had 2 points, and one of them was about the actions that we discussed we would take. Because I felt when I looked at the report under the actions, it wasn't actions, it was actually just some facts, so that would be good to put in as actions. The second point is on the overpayments graph.
Yeah.
I wasn't sure whether what this was telling us was overpayments that have been lost. So is it a financial loss graph or is it a behavioural graph? Because actually we recover some all of these.
So this is a behavioural graph because we need to make the behavioural change around, so specifically around late submission of leaver forms and change forms and things like that. So we're tracking the behavioural elements or the financial impact of the behaviour around overpayment.
So it's not an assumption that all of that is lost to the organisation. Right. Thank you.
Any more? Could I just?
I just wanted to echo what you said, actually. I mean, I think this is a really great report. We saw it at Quality Performance Committee, and I just think the way it's represented with SROs there, it's just the best version of this I've seen in the 3 years I've been here. Welcome.
Thank you. I just want to pose a question. I don't necessarily want the answer now. I know that in relation to quality metrics, there are 93 risks of quality, and I just wonder what's the progress on attending to those risks, and what are the actions? So if I could ask that to be taken away, because it just seems.
Can I clarify? I don't think that's 93 risks for quality. I think it's 93 risks being tracked through the risk strategy. We can take that away.
Really misread the data there. And I think the other point is to make it accessible to the public, that there should be a glossary acronym. So if there are no other points on this, can we continue then? And turn to the closed session information from meetings held in private on 24th of April, 1st of May and the 5th of June. There is that paper. Thank you. Any other business? If not, can we turn to the board reflection? So have we fulfilled our objectives as laid out in relation to our community, NCA colleagues and stakeholders? Start for 10 in relation to NCA colleagues, the colleague story with the emphasis on complementary therapies and well-being.
Yep. Good, strong.
Communities.
I don't feel as if they've beat today.
Sorry? Jeff?
And personally, I still miss input here from the council boards, from police-based needs, give a local flavour of our impact and how they see our challenges. I don't know how to do that, but something I particularly value.
Thank you.
Sure. I agree with that. I think there's a bit of a community's voice we're missing. I didn't think I heard about adult social care much today.
Chris.
Thank you. Just thinking about equality and thinking about our population, I'm not sure that we focused on that significantly. And it's something that I know from those of us that sat around the table how important that is. And yet within the reports that we have, still don't feel as though we are reflecting upon, especially. So how we do that to be subject of further discussion. It's something that we are, and it's understandable given the complexity of where we are, you know, the focus on budget, but we know how important it is to us. And yet I not feel we're focused on that sufficiently.
I think in response to that there has been some in the context of the maternity report. There was reference to the use of ethnic background and also levels of death deprivation. So, you know,
there is, and it's a big part of the improvement board and also questions of stress. I think in terms of the wider portfolio, it's not featured anywhere else, and that's one part of our change portfolio, and it's one part of our performance. So if we ask if there's something else that you focus on, that's not.
No, that's very good.
Yeah.
Not disagreeing. Are there any other comments? It does, of course, depend upon us all reflecting upon the board as we go through.
In terms of performance, I've got another point, and Jude will probably go, oh no, not again. It's about children, you know, and I think we mentioned it in terms of quality and performance, and I think something we ought to take back to that committee. If we were a children's hospital, we'd hear the child's voice. I know that's something I've said before. I just don't feel as though we do look at how long they wait for things. We look at speech and language. But what's the child's experience within our organisation? That's something I'd like to see back on.
Thank you. Yeah.
Make a connected point on the performance report. We've been doing this on a number of occasions, so we've got something that's, you know, people have positively commented on, rightly so. One of the trade-offs in presenting something in the way that we are, which is trying to distill and get some of the key points, is we're largely seeing an NPA-wide picture. You know, we're not seeing a picture of individual places, and even getting that data cut in that way is difficult for lots of obvious reasons. We're not seeing a picture by particular communities of interest or protected characteristics, except in exceptional areas. I think what we said when we had a bit of this conversation before set meetings is that we should make sure at minimum we are reporting by exception. So we are being clear in the report where there is where we may see, certainly aware of law averages, we may see our average performance across the NCA, but actually where we know that there are significant exceptions by any of those either protected characteristics or geographical areas, we should be making that more, should be really alert about that. I do think there is still a challenge for us about the way we more generally reflect some of the variation of our places and communities. But if it was easy to do, we would have done it already. It's important that we recognise that we haven't got there.
Thank you. Jude.
Yeah, I mean, they're all welcomes, aren't they? I go back to wants and needs, and you know, the capacity of teams. I think Alex would say it's out there, but you know, one of the challenges we had last year is we had metrics agreed and we couldn't report on them because we just simply haven't got the data systems in order to pull the information. So we've got to focus on what we've got and have development plans for the things that we can't see today. The children's piece, and you know, I'm with you, Chris, on that. Heather, it's on the Q&P work plan to bring the deep dive back that June Flaherty did, and to say where were we at that point in time and how have we moved on. So I can't remember. I think September from memory, because I think I did have a look at it where it was in the work plan. So I think September Heather's bringing it back.
Thank you. Lorna. So Carmen, then
I think Lorna's got this one then.
Lorna, then Carmen.
So
Then we finish.
So I was just reflecting that throughout this morning we've talked about how we triangulate information and data, and how we triangulate what one report or committee is sharing to a AAA versus what data is putting in it and another route. And there's something that links back to the performance report is an overarching trend that should give us a flashing beacon of where a trend is starting to change. And that helps us really think about where else is that information coming through, where's the granularity. So one of the conversations we had at QPC actually was about, in recutting the performance report, do you take it through a number of committees and put scrutiny on it? Well, actually it's a trend report. And the papers that come through our individual committees and our governance regime are the ones that deep dive and drop into the detail. So by the time we are looking at the overarching NCA view and a set of dashboards and metrics, we should be quite assured within our individual committee areas that we're understanding the data and we've had that level of scrutiny. So this is about aggregating up in the same way a change portfolio board data aggregates up. But my reflection is, are we bringing enough through on the AAA reports that really pinpoint that? So when we get to look at the aggregated view for the Northern Care Alliance, we are clear where there's a place impact, or we're clear where we have really flagged that the concern or an attention that we're dealing with in the granular data, that then this reassures us that the two match. And I wonder whether we just got a bit more maturity to do. And then if I may, this is a recut of the performance scorecard in an evolution. It will continue to evolve. We are maturing the information that we use. It will prompt us to say, oh, actually, we need to look at this as well. We will mature as we move forward in the narrative that we put around it. So I think we should expect to continue to develop it to really improve and strengthen that linkage with committee and here.
Thank you, that's a very helpful suggestion. Carmen.
Just a point, we were due to have a shadow board yesterday, and if the shadow board met, and it might not have done, is there any feedback from shadow board?
It didn't meet because the unavailability of the person who was going to share it, and no other colleague could do it.
Thank you.
It will be rescheduled for next month. Thank you. Date and time. Next meeting is Wednesday, the 7th of August. Thank you.